Morning, everyone. We're going to go ahead and get started. Hopefully everyone's awake and had breakfast. We have another exciting half-day lineup for all of you. Just a reminder to everyone, there is the CME info that I think is flashing up on the screen. So make sure if you are interested and eligible to get CME to go through the platform, sign up, do the pre-test, post-test, and evaluation so you can get your CME credits. So today we're very excited. We have a special speaker that's going to start off the day with us. Dr. Ron Su is a good friend and colleague. He's a comprehensive and advanced GI in Sacramento, a clinical professor of medicine at UC Davis, and he's our Northern California ACG governor. So all of us probably should be getting emails from him on a regular basis. If not, you need to sign up to become an ACG member. So he's going to talk with us today on a very special topic, and I think this is especially relevant for some of the trainees and fellows that we have on GI advocacy, how you can get more involved with GI locally, nationally, and some tips and tricks on how to get more integrated, especially with ACG. So welcome, Dr. Su.
Thank you very much. Thank you for the nice introduction. So today's talk is very different. It's not like what you heard yesterday or later. My talk is totally not in an academic type of content. First, I would thank the organizer, and you can see, Neil here. Of course, Neil visited me a few months ago, and he was in my office. In my office, I have two chairs. One is for the VIP, the other is for special needs. and I thank Robert and also Mike. I met Mike in the Congress this year, right? And I took a picture, and I met Robert in Vancouver last year. I think I meet many people outside than when I come here. But thank you very much for this invitation. I will start off with this quote. And before I ask, there are residents and GI fellows here, right? I'm so sure. You remember who Oslo is? In internal medicine. Yeah. So Oslo is famous for a physical sign, right? Remember? You know what that is? They're called the Osler node, right? And it is a sign for subacute bacterial endocarditis. I don't think we see it anymore. But Oslo is also a very, very good educator, almost like called the father of modern medicine. And he was the founder of the Johns Hopkins Hospital. Now, this quote I think is important. It says, "The good physician treats the disease," which we all, hopefully we are, and then the great physician treats the patient who has the disease. What I find important is during medical school, we learn how to treat disease, and in residency and fellowship, we learn how to be good physicians. Now, when I came out to practice, after a few decades, I realized it's much more than that. Say a third dimension. And the third dimension is what I'm going to talk about today. So we talk about physician advocacy. Now, physician advocacy is more than just advocating for patient advocacy. We are patient advocate, but I think we also need to make sure the patient can get access to us. So if we don't exist, they will have no doctor to see. So in terms of physician advocacy, we are trying to promote changes. The changes for the patient in many different ways, including social, economic, educational, and political. For us, we learn medicine. We don't learn about politics, but somehow we have to get involved because many times things are done because it's done. And we get to be involved so that we will do the job. And the work of physician advocacy is to actually reduce the suffering of the stress of the human health and well-being. And that is for our patients. And if we don't do that, there will be a problem. And it extends beyond the provision of good clinical care. So that's the part which is, I believe, is the third dimension of clinical practice. It's beyond clinical care, but it involves a lot of administration and different things. Now, so my talk is basically talk about how policies can shape our practice. And being an ACG governor, I'm going to give you some of the experience that I have and the priority that we set for this coming year. And I'll share with you if I have time, depends on how much time I have left, and I'll share with you some of the work that I've done up in Sacramento. Now, this graph here, basically you look at things, there are many ways to look at the implication of this. Now, basically it's showing the growth of physician administrators during the early days. Back in the 80s, I think we still had fee-for-service. Patient care is, and doctors are almost like direct, very direct. But since the 80s, late 80s, and turn to 90s, it started to grow with the HMOs and the health maintenance organizations. Now, basically, you look at the black line, the cost of medicine is going up, 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 up. And the physicians, number of physicians is going slowly up. But look at the yellow, under the yellow graph there. The administrators number has increased dramatically. So you can see cost goes up. Now, I don't look at it as a cost and stuff. I look at it as just a pure number. For every one physician, we have 25 administrators. Now, if you think about that way, and I never thought about it this, I think about if there are 25 administrators, one physician in any decision making, how many of those administrators are actually dealing with patient, with direct patient care? And then I realized when I go to DC, I think there's one physician, maybe 1,000 non-physicians making decisions for us. And so if we don't sit there, we'll have problem. So I'm so sure you hear about this. If you're not at the table, you're on the menu. We hear that a lot of times 10 years ago. But now what is worse, if you are not on the menu, most of the time it actually ends up on the table itself. We're being chewed alive. We will not exist. In fact, a lot of the primary or private practices is going to extinction because the medicine is being shaped in a way that private practice cannot exist if you are alone. And then we have to realize what is important. Is it just the way it should be or it should not? And so that's why it comes to physician advocacy. Now, over the last few years, I have worked with many different advocacy groups, and these are some of them. Of course, the big ones is our ACG with AGA and ASG, and I work with a few of the colorectal cancer advocates. And the ACS, the Cancer Action Network. So there are many more, and these are only a few that I was involved with. Now, the advocacy team with the ACG composed of these three teams. The ACG Board of Governors, which I am part of and knew also as the trustees and in the Board of Governors before. And we have the ACG Legislative and Public Policy Council, and together with the ACG National Affairs Network. So with these three, we promote all this advocacy agenda and what we do. So ACG is based in Washington, DC, and we have, of course, 50 states, but we have 70 governors. And why do you think there are 70 governors in 50 states? Because we also have some international governors, and we also include 3 governors from Canada. So the first, we have 3 different regions, 1 to 5 are all in the US. And in some states like California, we have, because California is one of the biggest states, we have 3 governors, and I represent the Northern California and the 2 governors are on the Southern. And my territory goes as north as the Oregon border down to Santa Barbara, but then there are a lot more, I think, people down in the South. So we have LA and San Diego. Currently, I'm doing I am the 5th region, the council, the regional council. So this is a picture taken about 6 weeks ago when we were in DC this year in April, and the entire Board of Governors are standing right there, Capitol Hill. Can you see me where else? It's very small, I'm on the second line. Neil, were you there? Yeah, no wonder I couldn't see you. Anyway, so that's picture. And this, the guy in the middle, right? He's from Louisiana. He's the current, you know who he is, right? It's our House Speaker, it's Mike Johnson. And then the 2 on the sides, one is our chair of the ACG Legislative Public Policy Council. And on the left side is Dr. James Hopley, who he was the past chair. So we meet a lot of people. They are very influential people, and some of them are very receptive. Some of them really don't understand what we're talking about, but unless we talk to them, they won't know what we're talking about. So we have to talk to them. Now, so here are all the trustees and the chairs, and our ACG president and our CEO. Now, as far as California, so these are the three governors, myself, and it is important. Why do I show this? Because we want to reach out to the members and also constituents and anybody who is in the GI field. And so here in Northern California, this is the GI Society that I relate to. In Southern California, they have their own. And it's our role to relate to everybody. And even if you are not an ACG member, I mean, your voice should be reflected. You know, anything you have concerns, please reach out to your president and group, or even reach out to me. I can receive any messages despite whoever you are from. You know, if you have concern in GI practices that you really feel something you want to do, let me know, because otherwise I would not know. And then we cannot voice your concern. So the only thing is I receive it, then we can reflect it to the Board of Governors. And then from there, we go up the ladder. Now, in 2022, which is this the slide shows, the ACG has done 400 advocacy messages with the federal and state issues, and 225 in-person or virtual meetings with the Congress and staff, and 10 meetings with the administration, Biden administration. And our goal is actually one voice for clinical GI practice. So ACG is one of the society or college that really focus a lot to help GI practices in terms of advocacy and training and promotion of health. Now I'm going to show you this example. I don't know whether you heard about this. Just a year, 2023, you know, we have all this step therapy approach and pre-authorization. We all know how painful it is. This is one of the examples I want to illustrate. You know, UHS, United Healthcare, in 2023, started to propose a implementation of pre-authorization for all procedures, colonoscopy, endoscopy. Unless you get pre-authorized, you cannot do it. So it really raised a lot of uproar, and we felt very uncomfortable. And so it will affect 27 million people. So the GI Society, including the ACG, would want to stop this unreasonable prior auth policies. So what did ACG do? So we started with some media outreach, and we joined forces with other GI societies, and also joined the advocacy rally. So the media outreach with the ACG president and governors, and we went out to media and talk about how unreasonable this type of practice is going to be, and how patients will lose access and lose care by all these policies. And then the ACG also joined forces with the AGA and ASGE combined letters. And within the 2 weeks' time, we got 175 organizations around in the nation and supported and signed onto the letter. And then we sent it to UHC. And this is the letter, the joint letter, and signed by our chairs and president, and 175 organizations. You know, they're so small, we don't need to read them, but basically we get support very quickly. But the thing is, we must take the action. If we don't take the action, nobody will know and will pass. And so we got support. We get back to the ACG and then the GI societies. And the day before they implemented, it was supposed to be June the 1st, 2024. They want to implement. And then on May 31st, our president, who is standing here, Dr. Dan Piamalco, and went over to actually the headquarters of the UHC and in Minnesota, together with the Crohn's and Colitis Foundation advocacy group, and then just stood there and showed them some forces from ourselves. And the next day, UHC actually abandoned the plan. I think that was a good move, but there's still a lot of behind-scene negotiation, because on one hand, they want to cut costs and not abuse of utilization of procedures and stuff like that. But on the other hand, they have to look into why we do it and how much suffering it will cost by doing that, and the cost involved. Now, so aims of advocacy, I make it simple. And now for us, we have to educate not for ourselves, educate the people who make the legislation. So our role is to educate the members of Congress and senators, advocate for the policy. We have to define what the policy is. And with them, they understand. Then we ask them as co-sponsor or sponsor to create and draft that bill, and then get to the House of Representatives or the Senate, put over the bill. And the eventual thing is to get a yay note. So it's a vote. So we have to have a yes, no, a vote to get it through. And so that process can be very long. Yeah. So just briefly go over the legislative process in the United States. So to create a bill, to become a law, it goes through all this. First of all, they have to write out and draft out the bill, and then put it and then introduce it. It goes through from the House of Representatives, it goes through some committees to the floor. And then after it's got passed, it had to go to the Senate and go back in circle, and then back down to the conference committee and the final approval. If it goes through well, it will then go through to the president and sign. If the president did not approve it, it can still go back, and then the Congress has some veto power, and hopefully it'll get through. But the process can take years. It's not just like, we introduce it, the next month it will pass. So we have to continue to educate. You know, to get the votes, it's not so simple. I never realized it's such a problem. You know, in the House, I think you know, we need a supermajority to pass any bills. And you know what's the number? You know what's the number of to pass? It's actually 218, I think. And then in the Senate, it's 51. So when there's 100, so the majority is 51 for the Senate. And I think it's 415 is the total number of Congress members. So it's 281 to pass. Now, so when the bill is drafted, you know where they introduce it in the House and the House floor. And so I just show you the picture. There's this little box there called the Hopper box. Is where they drop the draft. So when you introduce when they want to introduce the bill, they drop it there, and then the process start kick on. Once they receive it, they will assign a number. So with the HR and then a number. HR is like House Representative and the number of the bill. If it starts from the senator, we put an S in front of it. That's what I learned, you know, little things. Anyway, now, so in terms of what I have done, I was elected to be the ACG governor in 2019, took over from our superstar here, Neil Stoneman. It was such a big shoe for me to fill in. I almost tripped over. It was a lot of things that he did so good. I just didn't know anything about it, and it took me a time. So 2019, I took over in October. I was looking forward to go over to DC in April for the first time. And you know what happened in 2020? And so by March, the COVID hit so bad. Everything was like in short notice. Everything got canceled. So instead of going to DC, we virtually flew there. So actually, everybody stayed home, and then we sat through all this video thing. And so we met with different people, but virtually. And for the next 2 years, we did that. No, so in 2020, instead of doing all the other things we wanted to promote, the immediate need was so important, you know, like a lot of practices going down, the PPE and the money. So we had to advocate right away. You know, within 2 or 3 weeks, we had to come up with a lot of plans. And ACG did a very good job. So we started to promote so the importance we need, the fundings, you know, the emergency funding and the COVID fundings, all those things, together with other societies and I think many other colleges, pushed through. And then the Congress actually put in the money. You know all those, right? They give a lot of relief funds and stuff. So 2020 is what I did. In 21, we still do it virtually because it's still not open. And 2022 was the first time for me to be in person going to DC. And I was lucky and I was good that I have two young scholars with me. One is from Stanford, one from UCSF. I think you probably know Jessica, right? Jessica Rubin. And so they just joined me, and we actually were lucky. We won one of the few teams coming from Northern California. We were selected to go into the Capitol Hill. It was the first time I walked in there. And we were able to actually meet with the staffer. She's actually a doctor from Wisconsin, and she worked with the then House Speaker, Nancy Pelosi. So we went up to the office. It's interesting to go inside, you know, everything was, took us in the elevator, went up to the 5th floor, went into this conference room, and then it looks very nice. And I looked at some windows with some curtains, but they say those are all fake, fake windows. So it looks very nice, but I think they're so well protected. Don't worry about bombs, okay? And then the elevator's gone down. So it's an experience for me. And so we talk about all the issues like the step, care protocol and all those things and the reimbursement then. And then 2023 did similar things. And so This year, 2024, we went again, and there were 100 ACG leaders was there, and there were 200 meetings in the Capitol. One of the speakers was actually Bill Cassidy. You know Bill Cassidy? He's one of the senior senator from, I think, Louisiana. He's been there for a while. And in fact, he was a hepatologist, and he took up the legislation role, and he did a lot of work. So one of the things he quoted here is that, he said it's important. He almost gave us his practice, he's still practicing, but he does others. And he told us, if we bring an issue to the Congress or to the Capitol Hill, we must bring also a solution to propose, because otherwise they're going to hear your complaint and you're a complainer, don't do nothing. We have to have some solution. And he also says the advocacy always matters. Don't think that you say something little or nobody cares. If we keep telling them, educate the people who don't understand, and then we can make the changes. It's good for the patients, good for the practice, and actually, most important, it's good for our nation, the whole country, because you can see how bad it can get if we don't speak up. The healthcare is going up, and the patient not getting care. Why is that? Because there's one doctor, 25 other people who are making policies, who don't understand what patient care is all about. Yeah. Now, so this year, the priority, we went out and talked about these 4 things. 2 of the bills is basically related to prior auth. Prior auth has been a big problem for all specialties. In fact, we met some, I think we met some ophthalmology group, rheumatology group. They all go out and talk about this prior auth. It was a waste of their time and stuff. So I will briefly go over the Safe Step Act in a minute. And then the other is called Reducing Medical Unnecessary Delays in Care Act. So everything is a bill and it has to be very specific, written. Although they may be similar, but each one of them means something to the legislators. Then I'll talk about the reform physician reimbursement, and then access to colon cancer screening, and the 4th thing. Now, so the Safe Step Act, what is this? We have this step therapy. Many people believe that if we start from the least and go up to the top, and the step approach is the most cost-effective ways. But unfortunately, once we start practicing that, it is not true, because some of the people is already getting the top therapy, and you change insurance, you start from the bottom again. Those things are very not good for anybody, and it costs a lot of money and wasted resources to do that. And I'll talk to you, Bill, in a minute. And so the Safe Step Act, we started in 2021 or even before. In 2021, it's called the S464, and you see that by 2023, it changed it. So they sometimes have to change the words a little bit and put a new bill after 2 years. So this is 4 years in the run. And at least we have moved the needle a little bit, and then show you what's happened this year. Now, so this Safe Step Act currently is known as the S652 and the HR 2630. And why is it necessary? Because the step therapy protocols allows the insurance company to force our patients to try all the treatments before the doctors actually recommend, which is actually good. And the insurers say that it saves a lot of money. But then when you look at how much money they put into enforce this and how much money we try to fight it, it actually ends up to like $93 billion. Can you believe $93 billion and then doing all these things? So we suggest we need some reform. And so the bill says that we cannot just say no more step therapy. We just specifically look for certain situations where it will help. Especially, we want the insurance company to be transparent in terms of the process. How do they deny? Why do they deny? We want to give them a window to respond, not waiting for another 2-3 months to respond. Requires a time to be 72 hours at the most and 24 hours for any life-threatening situation. So that actually, I will show you that this year they heard it, and CMS is actually helping to get it done in 2026. Yeah, and so this bill is now gaining a lot of support, and 189 House representatives and 39 senators, getting close. Now, how do we get closer? That's why I'm here. And then in Southern California and any other states, we need the district representative to know this. They got to put a yay, okay? If they don't know about it, they just pass it and they just walk in, they don't even vote. it will never get past 189. We want it to reach, I think, 218. Okay, so that's the number. Now, so it's getting bipartisan support, and the bill hopefully will include it later this year. And I said 218 from the House and 51 from the Senate to pass this. Now, the other similar bill is this one, the Reducing Medically Unnecessary Delays in Care Act, the HR 52-113. Now, what is this? Why is it different? It actually basically requires all the Medicare plans to have medically necessary prior auth for both prescription drugs, but requires when we appeal, we talk to somebody who knows what we are talking about. You know, sometimes you answer the phone and those, I'm a GI guy, he's a radiologist, or he's a GI pediatrics. He doesn't know what we're talking about. A hepatologist who are talking to urologists, why is the drugs? No, we've denied it. So we are talking to like a wall. I mean, they don't understand anything. So we ask them to make sure if there is a appeal or they want us to talk, make sure we have somebody who knows what we're talking, maybe in the same field. So that's what we want to do, and without any delays. Yeah, and so some victories we say in this year alone, there's more than a dozen new laws being passed across the nation on this issue, and CMS actually issues the new prior auth reforms already, which we are very happy about. So by January 2026, which is another 2 years or 1.5 years, they will actually implement what we suggested. Now, so reimbursement, how much time do I have? I get to speed up. Yes. Now, this is so important for us. This is about reimbursement. I want to show you quickly here. Look at the orange, look at the blue line. It's going up, up, up. Let's see what they reimburse for inpatient hospital, outpatient hospital. And then you look at the consumer price index. It's go up every year. Now from 2000 to 2022, it's go up, up, up. Look at the physician reimbursements. It's like up a little bit, and it's so far. The gap getting bigger and bigger and bigger. And if you look at here, the codes, the one that goes down are the codes for the procedures. And then what goes up are the consumer price index and Medicare economic index. All this are going up. You know, cost and cost of living, everything goes up. The only thing goes down is what we're getting paid. You know, it's getting worse and worse. So we have to do some reform. And otherwise, there will be a lot of problems. We put it in the way that it will affect patient access and also consolidation of practices. You know, consolidation, that means there will be no more people practicing. They will go into the big health system and then become more and more inefficient. And then a lot of provider burnout. I'm so sure we all experience that burnout because we work very hard to what we can do, but now you on top have to deal with all these things. And then we hire some more people, it costs more money, isn't that true? So that's what we want to fight against. And I think we're making progress. Unfortunately, you know, we make a progress like this, they go worse like that. We have to keep pulling back, and we need a lot of support to do that. So the ACG holds some principles, what we do. We want to make sure that, the reimbursement to the healthcare is be reasonable. Unfortunately, this is not underlying to the words I want to tell you, but I can tell you. So basically, we want to make sure that the reimbursement is really reflecting so that there will be no major consolidation of the practices, provider burns out, decrease the slowdown of the healthcare innovations and technologies. And, the Congress and people, they call budget neutrality. They just want to be, we want to balance the budget. That's what they want to say. But when they balance the budget, they only balance what they think they want to pay. And unfortunately, we are the victims that they only cut us to balance the others. So we want to say, you have to make sure that the physician are not being the one being cut because you have no more access to patient care. So we want to make sure that we are on the other side rather than on the bottom side. And so we have a lot of support on that. So for this reimbursement, there have been challenges, and so other colleges supporting it. And in this last month, actually, the two committees already held some hearings. The House of Ways and Means Subcommittee and the House Budget Committee held some hearings on this. I think they're going to take some actions and then get the reform done for the physician purpose. Yeah. Now, the other things about access to colon cancer prevention and screening. So, in the HR 1570, removing barriers to colorectal cancer screening, You know what it is, right? Many years ago, patient gets screening, they come for screening, we do the colonoscopy screening, and then we found a polyp, pull it out, and tell the patient they have polyp. And then what happened? It's no longer screening. And this is after the fact we found the polyp. And that is so unfair to the patient. Patient always say the doctor write the wrong codes, and always claim that we are doing not the right things. But unfortunately, that's how it was made by law. So finally, that has been passed up to the letter. And then they start to understand that the colon cancer screening, even if you find a polyp, that should not, the patient should not be paying it. It should be part of a screening coverage. So eventually in the 116th Congress, that's during the COVID time, and that bill was put on the floor. And because of COVID, I think thanks to COVID, a lot of bill get passed because it is bundled together. And so this HR 1570, removing the barriers, passed on the floor quickly and with bipartisan support, almost unanimously. So, but you know how long it take from March 2019 until December 2020? This is one of the quickest one to pass like that. And so it took a little while, and you need the support from the senators and all the congressmen. Now, last year, I think 2021, we have another move forward. Now, so people do stool testing, right? Stool, FIT, and then DNA testing, and then they come for colonoscopy, that become diagnostic, right? So this one is another issue we brought up. And so in the California Assembly in 2021, Gibson was the assemblyman put in this on the floor, and with the support of the ACG and the coalition, Cancer Coalition, and the bill finally got passed and written into law that people who have FIT and stool test positive and getting a colonoscopy is still part of a screening, should be covered by the insurance without any copay. Now, yesterday you heard our president, and this picture was taken yesterday, you know, very nice, new. So basically, this was brought up by the AGA to the Congress. And so the Congress also passed it. So now it's nationwide, FIT positive, getting screening colonoscopy, and still part of screening. Now, the next step, what we're doing this year is, how about the people who have polyps? Patient diagnosed a polyp 5 years ago, come in asymptomatic in colonoscopy, and they label this as diagnostic now. Is it fair? No, I have a polyp 10 years ago, I come for screening, I'm totally healthy, and now I don't have the benefit as a screening test. So this is what we're pushing, that we are asking them to change the verbiage and make sure that even if the patient of polyp is asymptomatic person, they are still part of screening, so there's no out-of-pocket cost. And so this is signed out by Debbie Dingle from, I think, Missouri, and other co-sponsors support this. Hopefully, it will get done. Now, I'm going to share with you what I did in terms of advocacy. Now, advocacy can be what we did on all this legislation, but now I'm sharing with you some of the things that I did. I work with a lot of advocacy group, and we're basically raising awareness. This was a rally that we held in 2023, which is only a year ago. So with a few advocacy group, including the ACS and the Fight Colon Cancer Advocacy Group, so we had a rally in Sacramento. And that was a good, interesting event because we have first time bringing a big colon standing in front of the house of these people. And they were upstairs doing the meeting. And they were supposed to come down, but they were still in session. They couldn't come down. And so we left it there, but they actually saw it. And then we have the support from our ACG president, Dr. Irvin Pike came, and the president from the C4, Dr. Anderson. And here, you know, Mary Beth not here is, you know, her husband died of colon cancer, and she was really up. She felt very strongly that something was not correct during the thing. Now, down here in the middle, Spencer Dayton, you know, you look at this size. He was having a lot of GI symptoms, went to see doctors, and he looks young. He's in 30-something years of age. The doctors say, there's only a symptomatic problem. It's only in your head or some GI. So he got delayed, and because nobody paid attention to his body. And finally, he got found to have a stage 4 colon cancer. And they even think that he has Lynch syndrome. And so he was there and advocacy and saying that, you know, I don't know how many more weeks or months he can live, but he was saying that, you know, people have to understand when you have symptoms, talk to the doctors. Doctors have to be more receptive. And especially nowadays, you know, there's a significant rise in young age colon cancer. So we got to really put that into the equation now and cannot just brush it off. Even the symptoms are vague. We got to think about it because I see quite a few now, even close friend, neighbors, young people and die of colon cancer. They usually present very late. I don't know why, they're young and they have stage 3 and stage 4. And most of them, what I saw, some of them still living, but then some of them really, they cannot make it in a few years. Now, so this is one of the things I have. How do I click this? Okay, this is the event in the rally. So I can show you there's no sound, but I can wait. So basically we were in Sacramento and they were in session up there. And then we held it and I wish there's some sound here, but what we were saying that
Curable. Colon
Oh.
cancer is the third most common
good.
cancer in the United States. It remains as the second most common cause of cancer death.
These flags in front of you strung out in this portion represent the 5,530 Californians that are expected to die from colon cancer this year.
Educate yourselves. Help us. Volunteer. Even if you've never been affected, you can still be an advocate.
Yeah, so it's a very brief one, but we spent some time. Now, what happened? Following year, which is this year, so a California Senator, Dr. Nilo, and he actually put in the floor to declare March as the Colon Cancer Awareness Month in California. And so went on the floor, it was March the 4th, and by April the 4th, it was passed. So now California has that March is the Colon Cancer Awareness Month. It was nationwide, but this is the first time. I think what we did, I didn't know that they were looking at it because upstairs, but now I think maybe they heard a lot of advocacy and then they see that happening. So now we have this important things. So I did a lot of other things, and this year we did a very interesting colon cancer awareness rock concert over in Davis. And this event is one of the very interesting ones that I've never had before. We had the Trans-Siberian Orchestra original string master. When I asked him, he's coming to town, he's doing a tour in America, right? So I asked him, would you like to support this? He jumped on board immediately. He said, okay, 1,000% I support it. You know why he wanted to support it? He said his mother and his grandfather had colon cancer and died. And said he has a brother screen every year. I said, wow, it's too many times. But I said, you come and learn something. So he's so nice. So he came in and he brought his team. And so he's an electric violinist. You should look on the Wikipedia or wherever, go on Google. Mark Wood was his name. He's so nice. And I never met him. Okay. I met him when he came. I only spoke to him virtually. And so the Davis Enterprise publishes on the Sunday as a front page. And we have 350 performers, young musicians, and the whole Davis School District supported it. And we held back-to-back concert because there are too many people. The hall could sit 500, so we have 1,000 people. And it went very well. And there are a lot of media things, so it went published. Now, if you are interested, I don't know how much time we have, but this is the ACG outreach. We have the starring with Neil Stoneman. He is one of the stars in this video, and then many other ACG leaders, including Mark Wood. So it's a 30 minutes. So if you want, you can scan it down. And during this ACG 30 minutes, I also wrote a little song. This one, you can scan it. What I like is you can get this and send it to your patients. Listen to the lyrics. The music is only part of the background, but I think the message is to get screen. Why do you want to get screen? The lyrics tells you. Okay, can you scan it? I don't know whether it works. I just put it there. Do you think you get it? I posted on the YouTube. And this song, I wrote it because I was listening to Bon Jovi. And then it's called It's My Life, right? It's My Life. Yeah. I was thinking, It's My Life, we have to do something about it. And so I changed it a little bit. The song, I love the music. And in order to avoid, copyright, the song was played, every piece of the background music was played by my son using the GarageBand, so it's all original. The lyrics I wrote, And then the animation was done by my daughter, actually. And then I have the anesthesiologist daughter sang the song. She is actually the vocalist. It came out together so nicely, and so I want to share. Make sure you send it to the patient. There's no end to it. Anybody can listen to it from now to wherever, whenever. Okay. Okay, now the other bills that we endorse, all these, including the telehealth. Remember telehealth? We do not want it to go away. We're promoting that we continue it because it really helps a lot of people. Helps a lot of people. And many people want to stay home, they're far away, and it will do a lot. Okay, I will stop here. I think it got over time. Thank you. Okay, so open to questions, right?
Thanks, Ron, for just an amazing talk on all the amazing work that you've done. We have a few minutes for questions. Please go ahead.
It's really important. I think a lot of our trainees don't understand how insurance companies will affect how you practice and how every day, every patient encounter when you're an attending involves talking to patients about insurance and why you're doing treatment A or B or why you're doing a thing a certain way because of the insurance industry. My question is, the problems with what's going on is that a lot of insurance companies are starting to buy medical practices. So United is one of the biggest employers of doctors, right? So I have this vertical integration diagram actually was given to my office by United, which shows you how United owns Optum RX, which owns Optum Specialty Pharmacy, which owns Optum PBM, which owns, Optum Care. So United, this is just one example of the, the big, many big insurance companies that we are kind of under, owns the whole system. I was wondering, during the fight with United for the changes that they're trying to implement, did you notice that the ACG noticed if any of the doctors who are employed by United were hesitant to step up or say anything because their employer is United?
Definitely, definitely. I mean, and once you are in the organization, they tend to have always loyalty to what they are working for. They're hired for doing so. But if you don't agree with them, many of them will not stay in that environment, right? But I think for us, we have to open to the public and to everybody who has common sense to think about what is right. When it's not right, we got to speak up. We have turned healthcare delivery as an industry, as a business. Everything is a business plan, and every life is 0.1 cents per life or something like that. I mean, I find this very amazing. About 30 years ago, that's how it started, and it's ended up that way now. Everything is money, money. Of course, money is important, but I think we have to have the input from our workers. So this is a big organization. They are in control. There's no doubt they're in control. And you can see that some of the health system is going to buy up the insurance. I think I work in a system that they're doing that. They become monopolizing. And in fact, and then the government will fight them. I don't know. There's so much money being spent on doing this and doing that. And, 80% are doing with that, only 20% or less is doing patient care. They'll be increasing so much of labor work and resources, doing all those things, policies. But if you don't put it in the paper and put it in, and people have no way to go. So you're right. How do we make a difference? The powerful is more powerful because they have more money. And so our organization, we want to go to the grassroots. We want to talk to people like you and everybody here, and from the trainee, start from the training part and to the practitioners. And when we ask for support, sometimes we ignore them. I used to just don't look at this, nothing to do with me, right? But when we ask for support, we want you to send in the note and sign your name so that it goes to your district representative, because those representatives may not understand a thing. If you don't tell them, they don't know. But we need the whole nation, each area to support the bill, That's why if there's still, some areas they are very known, they will support it, but then other areas, then the number is still not enough. So I think that's why we got to get you involved into this and understand why we want to do it. And for you, it's very little. Just put a signature and click it in, that's all. But for us, we had to put a lot of work to make it happen. And we just hope that we'll move the needle bit by bit. And then some bigger ones can happen. And we don't know. Sometimes another COVID or something else, something would go through very quickly. But I don't want to have bad things happen, but I think the support has to come from everybody.
And I have a question for those in academic centers. It's been a long time since I was in medical school, but are there classes being taught about advocacy? Like, is that, does anyone know?
Yeah, how about UCSF? Anybody from UCSF, Stanford, in the medical curriculum, do they talk about advocacy? Well, we don't.
I mean, I think that's a very important topic, and I think that that's an area where we don't get enough education early on, and just sort of the realities of how healthcare is changing, regardless of what specialty you're in. I think unfortunately healthcare systems in the US are changing very rapidly, and some of the topics or issues you mentioned are reality. But I think to flip it around though, that's why it's so important for us to be involved with large societies, because there are power in numbers. And sort of joining ACG, AGA, and sort of lending your support and advocacy to these organizations that can sort of speak and advocate on your behalf, thousands and thousands of members. I think it's so important to advocate with that power behind you as opposed to sort of individual providers. But the last question on the same lines, we have a lot of trainees here and people maybe just starting practice. We've heard about so much of these amazing things that you and ACG have been doing. What's a good way for people to get started? Like, they may not have an idea of how to get involved or how much they want to get involved in. Like, what's a good tip or advice on how you can learn a little bit more, or maybe just...
Yeah. So of course, the first thing to do is to join the membership. Because once you get there, you get the resources. Now for residents and for, I think this is all free, right? It's cost zero. And then you can take part. In fact, we are hosting, this last 2 years, we host annually a workshop for residents. Can you believe resident before GI fellowship? So there's a workshop in the annual meeting, 2 days or 3 days. You can attend there, and we have special faculties to educate you with different information. And so if you are the resident and fellows, please sign up to the ASM for this year and make sure you register. Very popular. The resident one is the most popular session. And we have increased so many tables or session rooms for that. And we have also practitioners. During the workshop, we talk about foreign body extraction, and Dr. Newstomen will be the expert on that. And we have a GI leader, but then we also include residents session for that endoscopy workshop. Yeah. Yeah.
Well, thank you so much, Ron, for a
Thank you.
wonderful talk. So now I want to invite Dr. Lawrence Leung to introduce our next set of speakers.
Cool. Thank you, Dr. Su, Dr. Wong. That was great. We're going to switch gears a little bit into the liver. Our next speaker is Dr. Michael Lee, who is a transplant hepatologist and gastroenterologist at UCSF, where his research focuses on immune-mediated liver disease. Dr. Lee grew up on the East Coast in Massachusetts. He completed medical school and residency at Mount Sinai in New York before going to the Brigham for his GI fellowship. He then left Boston to complete his transplant hepatology fellowship here at UCSF. And in spite of the Warriors beating the Celtics that one year in the finals, he is still a diehard Celtics fan, but I think we'll give him a pass since they're back in the finals. I've had the pleasure of working with Dr. Lee in his liver clinic, and he is an outstanding teacher and an amazing clinician. Today, he will be talking about the updates and management of cirrhosis and portal hypertension. Thank you, Dr. Lee.
Thanks so much, Lawrence, for that very kind introduction. And thank you, everyone, for inviting me to speak today. So I'm primarily a researcher. I study liver cancer immunotherapy, but this is a topic that's very near and dear to my heart as a practicing transplant hepatologist, which is portal hypertension. This is a very timely talk because the AASLD just released their updated guidelines about portal hypertension just a few months ago. And so we're going to be going over sort of the key points from that with a focus on how we define clinically significant portal hypertension and what that actually means. I don't have any disclosures. So in terms of what we're going to be talking about, we're going to learn how to apply non-invasive assessments to diagnose clinically significant portal hypertension, identify indications for variceal screening and prophylaxis, utilize the current evidence base to decide when to start, and also, really importantly, when to stop non-selective beta blockers, which is a very hot topic. Recognize when a preemptive TIPS is appropriate, and then a short little bonus point right at the very end. And just to take a step back, the reason why this is so important, patients with compensated cirrhosis have a median survival of at least 12 years. And once that switch flips and you develop a decompensating episode, which is usually something related to portal hypertension, all of a sudden your median survival drops all the way down to 1.5 years without a liver transplant. So like I said, this is going to be mostly focused on the most recent updated AASLD practice guidance. The previous version came out in 2017. In between that, the Baveno 7 guidelines came out, and then the AASLD practice guidance came out a few months ago. So here we have the different stages of chronic liver disease. On the left, the first column, which says no cirrhosis, you see patients without cirrhosis who by definition don't have portal hypertension. In the middle column, you see patients with compensated cirrhosis. And remember, these are patients who have an expected median survival of 12 years. What's able to best stratify these patients in terms of risk is the presence or absence of clinically significant portal hypertension, which we define as a portal pressure gradient of 10 or greater. Clinically significant portal hypertension is a phrase that's brought up again and again and again in the new AASLD guidelines, in the Baveno 7 guidelines. It's a strong predictor of hepatic decompensation, which then moves us further to the right. So the last column on the right is our patients with decompensated cirrhosis, which is actually split for the first time into two different categories. We have first decompensation as well as further decompensation. So first decompensation makes sense. It's the first time you developed a decompensating event. And then we have this new concept of further decompensation. The latter, so this means developing successive complications of liver disease, which is recurrent variceal bleeding, refractory ascites, hepatorenal syndrome, SBP. So unsurprisingly, the patients all the way at the right are at the highest risk of death. While we can measure an HVPG invasively using a transjugular portal pressure measurements, this is invasive. It's often unnecessary unless you need a liver biopsy for another specific reason. So this leads us to a really important topic, which is how to non-invasively detect or define clinically significant portal hypertension. So this is a figure from the new AASLD guidelines. It's a little bit busy, but I'm going to take some time to sort of walk through it step by step. So the first row, the first row at the top is the different stages of liver disease combined with likelihood of having clinically significant portal hypertension. The first row is liver stiffness measurements. I'll note that this is specifically defined as using FibroScan or transient elastography, which is the technology with the most well-defined cutoffs. You can see that a liver stiffness of less than 10, so then this part in green, rules out cirrhosis. You go one column over, and then you're in the probable cirrhosis column. So a liver stiffness between 10 and 15. So you probably have cirrhosis. It's almost certainly compensated, and clinically significant portal hypertension is unlikely. And it can be completely ruled out if you have a platelet count greater than 150. So here's your liver stiffness less than 15, platelet count of over 150. That essentially rules out clinically significant portal hypertension. You go one more column to the right, and here are patients with certain cirrhosis. And then here's where risk stratification in terms of whether or not they have clinically significant portal hypertension is much more important. And so if their liver stiffness is less than 20 and their platelet count is greater than 150, this rules out varices-needed treatment, which is this box right here. And we're going to zoom in on that on the next slide, just so that you can remember the really, really key important numbers here. Conversely, a low platelet count, so less than 110, really increases your probability of having clinically significant portal hypertension. That makes sense. If you have portal hypertension, you develop more splenomegaly, and then your platelet count goes down. And then further to the right, you see that the liver stiffness over 20 is very, very is associated with a very high probability of clinically significant portal hypertension. If you have a liver stiffness greater than 25, you don't even have to think about it. Patients do have clinically significant portal hypertension, but also if you have a platelet count less than 150 with a liver stiffness of over 20, that also counts. There are some cutoffs or proposed cutoffs down here for ultrasound or MRI elastography, which may be more accessible than FibroScan depending on your practice and where you are. There are some soft cutoffs. There's actually a separate AASLD guideline that came out earlier this year as well, talking about non-invasive liver stiffness measurement. This mostly reflects those numbers that are published in that guideline. These are less well validated than FibroScan and are subject, especially ultrasound elastography, is subject to some cross-manufacturer variability. That's actually why you see, if you see ultrasound elastography reports, they'll mention the manufacturer, because that's important because different manufacturers have different cutoffs, and so that makes things a little bit more complex. I would say in general, if you're in the green to yellow range, it's probably acceptable to sort of use as evidence that people don't have clinically significant portal hypertension. But once you're starting to get into the more right side area in the orange and red, it might not be the best idea to just use those measures to define clinically significant portal hypertension. All right, so that was a lot of talk, a lot of numbers. I just wanted to zoom in and really focus on the numbers that people should remember. So to reiterate, if you have a liver stiffness of less than 20 and a platelet count greater than 150, that rules out varices that need treatment. You do not have to do variceal screening for those patients, and so you can safely avoid doing endoscopies. That also means that you should be doing annual FibroScans in these patients, because obviously patients' liver stiffness can progress. So if you are choosing to avoid doing variceal screening in patients because they have a low liver stiffness and a normal platelet count, just remember that that should be something that's repeated on a yearly basis to make sure that they are still within that category. Okay, so we've talked about non-invasive clinically significant portal hypertension assessment. Let's talk about non-selective beta blockers, which, as I mentioned, is a very hot topic right now. So the PREDESI trial was published in The Lancet in 2019. It's the strongest evidence thus far of clinical benefit associated with non-selective beta blocker therapy. So this was a trial of 201 patients with compensated cirrhosis. They all had proven portal hypertension based on transjugular portal pressure measurements. And notably, they actually gave patients IV propranolol while they were doing the measurements. Every single patient responded to IV propranolol. This is not something that we do routinely when we're doing portal pressure measurements. So this is outside of the scope of standard practice. And really what they're doing is selecting for the best patient population, patients with portal hypertension who are going to respond to a beta blocker. So very highly select patient population. Ultimately, half received placebo, and then half received either propranolol or carvedilol, and their primary outcome was hepatic decompensation. And so what they found is that beta blocker treatment reduced the risk of hepatic decompensation, predominantly by preventing development of ascites, and did not increase risk of adverse events like hypotension. There's a couple caveats, including what I mentioned about the IV propranolol during the HVPG measurement, which is not something that we do clinically. The mean beta blocker doses were pretty high, not totally outside of the range of what we would normally use in clinical practice, but certainly on the higher side. So it wouldn't be uncommon that patients wouldn't tolerate these doses. And then most patients in the study had untreated Hep C. This was the enrollment period was sort of right around the time when DAAs were coming out. So we don't really have, this is not really our patient disease population anymore because we have DAAs we can treat and cure Hep C. So how do you choose a beta blocker? So this is actually an older figure from the 2017 guidelines that they removed from the 2024 guidelines. I'm including it here because I really like how it explains the pathophysiology of portal hypertension and how non-selective beta blockers affect portal hypertension. So two things contribute to your portal pressure or portal pressure gradient, which is the flow and the resistance. If you think back to high school physics, you might remember Ohm's law, which is voltage equals current times resistance. Voltage is simply the change in pressure across the system. Current is flow and resistance is resistance. So Ohm's law can be pretty easily converted to fluid dynamics. And so in sort of fluid dynamics, you rewrite that equation as your HVPG equals your portal flow times your portal resistance. And so if you want to reduce your HVPG, you have two ways to affect that, either the portal flow or the resistance. So non-selective beta blockers act in two different ways. Oops, sorry. How do we go back? There we go. In the red box here and here. Beta 1 blockade decreases cardiac output, which decreases portal flow. Beta 2 blockade causes splanchnic vasoconstriction, which also decreases portal flow. So general non-selective beta blockers are all about decreasing the flow side, which works. But you have carvedilol, which is the most effective non-selective beta blocker because it also has some alpha-1 antagonism, which causes intrahepatic vasodilation, as shown. There's a carvedilol extra mechanism, and therefore reduces resistance. So it's actually affecting both variables that that affect portal pressures. So unsurprisingly, there's very good evidence that carvedilol is the most effective beta blocker, more so than nadolol or propranolol. With the caveat being that because the alpha-1 blockade also causes systemic vasodilation, carvedilol also affects your systemic blood pressures more. So patients may not be able to tolerate it depending on their blood pressure. So as you may have noticed, there's a major movement towards much more aggressive non-selective beta blocker therapy. So that begs the question, who should we be treating? So patients with compensated cirrhosis and no clinically significant portal hypertension, ASLD and Baveno do not recommend starting non-selective beta blocker therapy. I will say in clinical practice, if they have reasons to already be on a beta blocker, if they have cardiac conditions, AFib, heart failure, if they're on a beta blocker for blood pressure, which is suboptimal anyway, I'll often ask their cardiologist or their treating provider if we can just switch them over to carvedilol, just because you're killing two birds with one stone. So the optimal patients to treat are those with compensated cirrhosis, so they can still benefit from not progressing to decompensation, and clinically significant portal hypertension, which, as a reminder, we can evaluate for non-invasively. As an additional benefit, if you start these patients on a non-selective beta blocker to prevent hepatic decompensation, if they're on a good therapeutic dose, you also do not need to do screening endoscopies for them. As either non-selective beta blocker therapy or variceal screening and banding as needed are reasonable options for primary prophylaxis. So you can choose one or the other. So there are some general contraindications to non-selective beta blockers. Some patients can't tolerate them because of hypotension. Bradycardia and AV block are relatively significant contraindications to giving a non-selective beta blocker. And if you can't give somebody a beta blocker and they have, and they're likely to have clinically significant portal hypertension based on those factors that we already talked about, then yes, those patients are going to need variceal screening with EGDs. If you are doing the endoscopic approach, these are the ASLD guidelines. They're pretty aggressive, 2 to 4 weeks until obliteration, then repeated 6 months, then every 12 months. Maybe 2 to 4 weeks is a very short interval, but I just wanted to point it out to sort of emphasize the importance of relatively short interval endoscopies if you're going down that pathway. So what about decompensated cirrhosis? There's some evidence that non-selective beta blockers can be harmful once you hit sort of a certain threshold. So this was a retrospective study of patients with refractory ascites, and they found that non-selective beta blocker treatment was associated with decreased survival. I will say that half the patients were on very, very, very high doses of propranolol, so that's that may be sort of driving some of this effect. Another study looking at 600 patients with ascites before developing SBP, beta blockers were great. Non-selective beta blocker treatment, just like they saw in the PRODESI trial, was associated with decreased risk of death. In the subset of patients who developed SBP and remained on non-selective beta blockers, non-selective beta blocker treatment increased the risk of death. So there's probably some window period during which a beta blocker is great, and then you get too sick and you are at higher risk of developing more adverse events like hepatorenal syndrome, things like that. And then all of a sudden you're past that window period, and the beta blocker may no longer be helpful and actually may be harmful. There's a lot of conflicting evidence here. There's lots of studies that have looked at this. Some have shown that beta blockers are totally safe in patients with decompensated cirrhosis. Some have shown that they aren't safe, as the ones I mentioned. There's still a lot of debate in our field. I think, what the main takeaway point here is that there are some mechanistically sort of feasible reasons why non-selective beta blockers might not be safe in patients with decompensated cirrhosis, and so the AASLD guidelines take that into account, which we'll talk about now. So let's circle back to the AASLD guidelines in terms of non-selective beta blocker therapies. So what they say is, you can either do non-selective beta blockers or band ligation if you find high-risk varices on EGD, but a preference is given to beta blockers because of benefits beyond preventing variceal bleeding, which are really the preventing further decompensation. If you are giving beta blockers, they should be dose reduced or discontinued in patients who develop persistently low blood pressures. So they define that as a mean arterial pressure, a systolic blood pressure of less than 90, or severe adverse effects. My opinion is that we should also probably use them with caution in patients with refractory ascites or a history of SBP. Those are just sort of signs that the liver is getting worse, that you may be sort of out of that window period, and you may be at higher risk of triggering even further hypotension, which then can lead to renal dysfunction. Just to finish up the non-selective beta blocker part of this talk, just wanted to mention dosing. Like I mentioned, we love carvedilol. We want to use carvedilol a lot. Carvedilol also makes your lives a lot easier because you don't have to sort of titrate it specifically to blood pressure or heart rate goals. You still have to watch the blood pressure and the heart rate, but you don't have to continue up titrating it until you hit that heart rate of 55 or that blood pressure of 90 systolic. The therapeutic dose is 6.25 milligrams twice a day, so a total of 12.5. We usually start off at 6.25 once a day, and then after 3 days or so, as long as they're tolerating it, you just bump up to the full therapeutic dose and you're done. Obviously, a lot of patients are at higher doses in general. For heart failure, are going to be at much higher co-reg doses. That we leave up to the cardiologist. As long as you're exceeding the 12.5 milligrams per day, you are considered to be therapeutic from our perspective. Here, I also listed some of the doses for nadolol and propranolol. Those are a little bit more tricky because you do have to sort of up titrate them pretty aggressively and to a target heart rate and blood pressure goal. All right, so that was the main chunk of my talk. We'll talk about a little bit about tips and then one more thing, and then we'll summarize everything. TIPS are a transjugular intrahepatic portal systemic shunt. Just as a quick reminder, it bypasses the portal system. It decompresses portal pressures. It's really useful for ectopic variceal bleeding, so places where you can't necessarily band, like esophageal varices. If you have small bowel varices, rectal varices, TIPS is the treatment of choice. There are some contraindications. The MELD score was originally developed to predict post-TIPS mortality. So we actually, and now obviously as transplant in the transplant world, we use it for listing purposes. But high MELD, pulmonary hypertension, or right-sided heart failure, because you're basically bypassing the high pressure system in the liver, and suddenly you're exposing the heart to a bunch of venous return. So if they have right-sided cardiac issues, they may not be able to tolerate that. This is a landmark trial from now over 10 years ago in the New England Journal of Medicine, looking at early TIPS and variceal bleeding, and the early TIPS group had significantly lower risk of rebleeding and lower risk of mortality. And so there's a couple different concepts for TIPS. A preemptive TIPS, which is in patients who have had a variceal bleed and have been treated. The AASLD recommends a preemptive TIPS within 72 hours after initial endoscopic therapy in high-risk patients, which they define as Child-Pugh B7 and active bleeding patients or Child-Pugh Class C patients. Following the bleed in the absence of absolute contraindications. And then a salvage TIPS is one that's used for uncontrolled variceal bleeding. So these are really very sick patients. You do a scope, you're not able to control the bleeding, they go straight to IR. And then rescue TIPS, if patients don't get a preemptive TIPS and they rebleed in the future, despite vasoactive therapy and endoscopic ligation, that's what we would consider as a rescue TIPS. One last bonus point before I sum things up. This is also specifically in the AASLD guidance, and hopefully this makes your lives a little bit easier if you're on service and you're consulted to do an endoscopy. Routine upper endoscopy is not recommended prior to TEE. This is something that I think we get called about a lot. I highlight this because one of the studies that the AASLD guidelines cites was actually one that I did with one of my co-fellows back when we were in GI fellowship. So take-home points. Clinically significant portal hypertension, I use that phrase a lot today. We define that as a HVPG of at least 10. You can rule it in or rule it out non-invasively using various cutoffs. The most important cutoff to remember is the liver stiffness less than 20 on FibroScan and a platelet count that's normal, so 150. Rules out varices needed treatment. Carvedilol, Coreg, is the best beta blocker. The dosing is 6.25 daily, and then you just go up to twice a day after 3 days. And the best use for beta blockers is in compensated patients with clinically significant portal hypertension. Consider stopping the beta blocker if people have low blood pressure, refractory ascites, develop SBP, basically sort of progression of their liver disease. Please also refer them to us because those are patients who probably need to be evaluated for a transplant if they're candidates. And then consider a preemptive TIPS in high-risk patients with variceal bleeding. And that's it for me. Thank you.
Thank you, Dr. Lee. That was great. Our next speaker is Dr. Marina Reutemann. Dr. Reutemann wears many hats, including clinical professor and the liver program director at UCSF Fresno, in addition to serving as our NCSCG president. Dr. Reutemann went to medical school at OHSU before completing her residency at Mount Sinai in New York and a medical education fellowship at John A. Burns School of Medicine in Hawaii. She is a fellow of the AASLD and ACP. Today, she will be talking about updates in steatotic liver disease. Thank you, Dr. Reutemann.
Well, thank you so much for this kind introduction. And today we're going to talk about updates on steatotic liver disease. And when I first was asked to speak on this topic, and I was like, seriously, this is going to be really boring. Everybody knows already. And then I got a call, actually, not too long ago from one of the primary care providers in the Valley that referred to me. And pretty much everybody in the Valley has my phone number, and people use it fairly judiciously. So I always answer it, even if it's an unknown number. So this PCP, when they called me, was quite upset. And he's like, what in the world are you diagnosing my patients with? What is this MASLD thing? And I thought, uh-oh, maybe I really should talk about MASLD and name changes and everything. So we're going to spend some time talking about it today. Okay, these are my disclosures. NAFLD got renamed, or fatty liver disease got renamed. And I think overall it's a good thing. You know, briefly, the reason it was renamed because people were unhappy with the number of things in the NAFLD. First, N is kind of a non-thing. This is just not a good way to start. Patients were unhappy with the use of the word fatty, fat shaming, whatnot. Alcohol was an issue, especially in the communities where alcohol is, very much frowned upon or prohibited. So hence the name. So overall, now the umbrella term is steatotic liver disease. And under that umbrella, we have first MASLD. So it's a little bit of a mouthful, but bear with me. It's called metabolic dysfunction associated steatotic liver disease. And I want to point out that the D is silent, which makes it a little tricky. So under that umbrella, we have two things. One is metabolic dysfunction associated steatotic liver, or MASL, formerly known as NAFL. And this is basically fat in the liver, which is not causing any harm to the liver. Now, the more ominous subheading is MASH, or metabolic dysfunction associated steatohepatitis. And this is fat in the liver that's causing inflammation, which eventually will progress to fibrosis. So the next column, I'm actually really excited about. So this is called MET-ALD. And basically, in the past, before this name change, we had to put the patients in one of the two buckets. One is fatty liver disease in patients who don't drink, and another one, patients who do drink. And there was nothing in between. But what were we supposed to do with patients who do have metabolic risk factors and also drink? So now we have a category called MET-ALD, and a vast majority of the patients that I see probably fall into that category. And basically what it allows us to do is to classify the patients who have a lot of metabolic risk factors and drink a little bit, all the way to the patients who have a lot of metabolic risk factors and drink more than a little bit. So the cutoff point in terms of the alcohol consumption is 50 grams of alcohol per day for women and 60 for men. Next, we move over to the alcohol-associated liver disease, or ALD. No explanations needed. Then we have specific etiologies of steatotic liver disease. We will not focus on those today. And the very last, in a very small box, of cryptogenic steatotic liver disease, which used to be a lot larger when we didn't realize that a lot of those patients were suffering from MASLD or MASH. So you want to ask, how will it change my practice? How does this change affect what I do on a daily basis? So first of all, MASLD replaces NAFLD and MASH replaces NASH. So the good news is the studies suggest that there's a 99% overlap between MASLD-defined population and NAFLD-defined population. So this is great. So basically all the recommendations or AASLD practice guidance for NAFLD still apply to MASLD. And the results from the biomarker validation studies are for the same, applicable for patients with MASLD and NAFLD. So how do we define MASLD? So this is defined as presence of hepatic steatosis plus cardiometabolic risk factors. So we need at least 1 out of the 5 CMRF, so cardiometabolic risk factors. And you know all of them. This is BMI greater than 25. We have to remember that we do drop a couple points for patients of Asian descent, or waist circumference of 94 centimeters for men and 80 centimeters for women. We need to have elevated fasting glucose or hemoglobin A1C greater than 5.7, or diagnosis of diabetes. We need to have elevated blood pressure or diagnosis of hypertension. We need elevated triglycerides or being on lipid-lowering agents, or decreased HDLs, different cutoffs for men and women. This classification excludes patients with increased alcohol consumption. So now we're going to talk about MET-ALD. And I'm realizing I'm very short and I can't quite see my slides, but that's okay. We'll go from there. Anyways, that's why I'm trying to look like that. Anyway, so MET-ALD is a combo deal. It's hepatic steatosis plus cardiometabolic risk factors plus alcohol consumption. And the cutoffs for alcohol consumption for being included into the MET-ALD is women can consume up to 50 grams of alcohol, and men can consume up to 60 milligrams of alcohol. So now the tricky part is in the United States, one alcoholic drink is considered to be 14 grams. However, in Europe, it's 10 grams. So in the guidelines, we're using European measurements. And, you know, Europeans always do everything better, right? So it's a lot easier to count in 10s than to count in 14s, but this is the way it is. So the joking aside, the reason that I like this MET ALD is because we know that there's in patients who consume significant amounts of alcohol, there's an alteration in natural history of disease and treatment response. So this is awesome to have this category. Now let's talk about drinking and how much drinking is too much. And the old joke goes that too much drinking is one drink more than your doctor drinks. So, and I went to dinner with a few of you yesterday, so I know how that goes. But anyway, again, joking aside, if you have a beer, a 12-ounce can of beer, this is considered a one drink. If you go to a brewery and have a pint, this is actually 1.5 drink. Moving on to wine, one glass of wine with an alcohol content of 12 to 13% is considered one drink. Well, now we know that our robust California wines that we love has, for one, a higher alcohol content, and for two, one drink is really not what is currently served in the high-end restaurants. It's more of a bowl of wine that you get served. So keep that in mind. When it gets to the hard liquor, that it gets really fascinating. One drink is a mere 1.5 ounces. When you go up to a pint of liquor, which I know a lot of my patients drink and a lot of your patients consume, is 8.5 drinks. A bottle or 750 cc's of hard liquor is actually 17 drinks. That's a lot of alcohol. And unfortunately, a lot of my patients do consume that. So we'll talk briefly about molecular and cellular pathogenesis of MASLD. So first of all, this is what our patients consume a lot. This is not a joke. And a lot of our patients really lead very sedentary lifestyle. So the problem is the caloric intake exceeds the caloric needs of the body. So as a result, our hepatocytes become very unhappy. They're bloated. This leads to insulin resistance, and also because the hepatocytes cannot consume all the energy that we are feeding it, it's going to allow free fatty acids to float around. On the other hand, we consume a lot of, or our patients consume, I'd like to think that none of you consume this in this audience, but our patients do. So when the patients consume excess sugar, there's actually de novo gluconeogenesis liponeogenesis that happens within the hepatocytes, and that also produces a bunch of free-floating fatty acids. Now, free-floating fatty acids are not good for the body. They lead to oxidation stress, ER stress, inflammation. So lots of unhappy things that are happening in the body. So inflammation, fibrinogenesis, and DNA damage are all consequences of free fatty acids floating in the system. Inflammation leads to steatohepatitis. Fibrinogenesis obviously leads to liver fibrosis and eventually cirrhosis, and DNA damage is at the core of why our patients are at risk for hepatocellular carcinoma. Moving on. So what do I need to do in my clinical practice now that we know all of this? Well, first of all, we need to think about and identify patients at risk for steatotic liver disease. We need to incorporate screening for patients with steatotic liver disease into our practice. We need to identify and refer patients with advanced disease to hepatology care. And we need to know how to comprehensively treat patients with early disease who may not need hepatology care at the moment. So key points from the AASLD guidelines. So first of all, MASH plus fibrosis, F2 to F4, confers a high risk of liver-related events and therefore is called at high risk MASH. The rates of fibrosis and decompensation are not the same for each patient. It's not the same trajectory. It depends on the severity of the disease. It depends on the environmental factors. It depends on genetics. So it's not the same for everyone. Now, we always talk about cardiovascular disease for patients with steatotic liver disease, and that is certainly true for patients with early fibrosis, so lack of advanced fibrosis. So we definitely do need to pay attention to cardiometabolic risk factors and manage those. However, in patients with advanced fibrosis, death from liver disease actually predominates. So that's important to remember. So, if this steatotic liver disease is suspected, it does take an effort, a conscious effort to switch the terminology. So, in the primary care setting, we would start with a primary risk assessment and calculate a FIB-4 score. So, ideally, the FIB-4 score is incorporated into your EMR, and it just pops up as a reminder for you. I know how much you all love the reminders. So if the FIB-4 score is less than 1.3, then your patients are doing great. So you're going to reassess, every 1 to 2 years if they have less metabolic risk factors, or if they have more metabolic risk factors, or potentially every 2 to 3 years if they have less. Now, if the FIB-4 score is greater than 1.3, then you're going to proceed to the secondary assessment. And vibration controlled transient elastography, as we talked about, is the most validated way to determine the degree of fibrosis and degree of steatosis. And I want to emphasize that the vibration controlled transient elastography, also known as FibroScan, is not the same as ultrasound-based technologies. So I want you to be aware that sometimes patients undergo the ultrasound-based assessment and then they come back with inaccurate results. So we do not want to take it for granted. We want to make sure that they've got the most validated way of determining that. There's also another way to do it is a blood-based test called ELF, and it is pricey. So we do want to make sure that it's either covered by insurance and that the patients are not burdened with excessive cost. Now, if you have performed a secondary risk assessment and it's low, then we're good to go. We revert to the routine screening. If it's high, then the patients should be referred for hepatology care. And of course, every rule has an exception. If original FIB-4 is greater than 2.67, then the patient should go to hepatology care right away. So what happens when they do go to the hepatology care? This are the patients with the secondary risk assessment of intermediate or high fibrosis. So sometimes we may consider doing a liver biopsy. If our non-invasive tests are indeterminate, if there's the consideration for other disease processes such as autoimmune disease, or if the liver enzymes are persistently elevated. So biopsy may be considered, and biopsy is still our gold standard. And if we have stage 1, we're good to go, reassess in 2 to 3 years. Stage 2 to 3, we're definitely going to reassess annually, may consider pharmacotherapy. And in stage 4, we'll proceed with the cirrhosis-based management. Of course, again, there's always an exception. If there's clinically obvious evidence of cirrhosis, or ELF, if you happen to get it, is greater than 11.3, then we'll proceed directly to cirrhosis-based management. So alcohol consumption in the United States has increased, and alcohol consumption has been increasing prior to COVID. But certainly since COVID, we've seen an uptick in alcohol consumption in young patients, in women, and it dovetails to the increase in alcohol-related hepatitis and overall alcohol-related liver disease. So between 2019 and 2021, we went from 2.38 gallons consumption per year per person to 2.51 gallons per person per year, which is a 5.5 increase. That's a whole lot. Pretty much everywhere in the country, alcohol consumption has increased. So the part of the question that I've always asked is, certainly we've seen increase in alcohol consumption even prior to COVID, and COVID has exacerbated it. But why are we seeing such sick patients? What is happening? And I think what is really happening is a combination of patients with obesity, unhealthy eating, cardiometabolic risk factors, and increasing alcohol consumption, which leads to this massive uptick in patients who are very sick and oftentimes need advanced hepatology care and potentially transplant. So this is the reason that we want to really pay attention to alcohol consumption in our patients with MASLD. So this is a study by our own Dr. Robert Wong, and this looks at a very large VA population, 1.1 million patients. It compares patients by the degree of alcohol consumption. And what Dr. Wong found is that a high risk of alcohol use is associated with a 43% greater of cirrhosis compared to no alcohol use. So this is really kind of the final nail in the coffin of the idea that drinking red wine is maybe good for us or good for patients with steatotic liver disease because it may decrease their cardiometabolic risk factors. So that is not the case, and it simply increases their risk for cirrhosis. So this is briefly a modeling study of what is going to happen with our patient population if the drinking increases for 1 year. We're going to have 8,000 more alcohol-related deaths. We're going to have almost 19,000 more cases of decompensated cirrhosis, and 1,000 more cases of HCC. Well, now the pandemic is 4 years old, and we have not stopped drinking as a society. So the deaths are going to continue to increase. So that means that we're all going to be very busy, and we're going to need to know how to take care of these patients. The cost of alcohol-associated liver disease continues to increase and will continue to increase unless there's a systematic government intervention, as Dr. Su had told us, is necessary in order to stop this from happening. So what is the connection between alcohol consumption and MASLD? Well, briefly, part of it is genetics. And we know that there are certain genetic predispositions, most well known as PNPLA3 genetic polymorphism, that predisposes patients to increased steatohepatitis as well as increased fibrinogenesis. Well, more and more we're finding out that other genetic polymorphisms, in addition to PNPLA3, not only play a role in MASLD, but also play a role in alcohol-related liver disease. So how do we put it all together? So MET-ALD, most of our patients are going to fall into the category. So how do we approach them? So the way I envision approaching them, if you have MASLD predominant disease, we will identify and manage cardiometabolic risk factors. We will screen and treat for alcohol use disorder. We cannot forget that these patients are at risk. We will screen for advanced fibrosis, and we'll treat them with disease-modifying liver drugs. Do you like that term? I'm really proud of that one. In alcohol predominant liver disease, we will screen and treat primarily for alcohol use disorder. And treatment does not mean to tell patients just to stop drinking and go to AA. This is a lot more comprehensive than that is. We do not want to forget about cardiometabolic risk factors for these patients. We also screen them for advanced fibrosis and again, treat them with disease-modifying liver drugs. So what about disease-modifying liver drugs? Are they here yet? Well, at least one of them is here, and this is really exciting. This is the one that is not really quite here yet. This is semaglutide. And you all remember the placebo-controlled trial of semaglutide in MASLD. This was a phase 2 trial, which showed a resolution of NASH, but did not reach significance in resolution of fibrosis. So certainly phase 3 trial is in process, and we're looking forward to the results of it. But we do have currently available medication for treatment of patients with MASLD, and that's resmetirom. So this was also published as a phase 3 trial in New England Journal of Medicine. And this is the first medication that has achieved both resolution of NASH without worsening, MASH, without worsening of the fibrosis, and improvement of fibrosis without worsening of MASH. So this is fantastic. And we now have a medication to offer patients with MASLD. So what is resmetirom? Resmetirom is a partial agonist of THR beta. Basically, in the way I explained it to patients is we need a healthy thyroid to have a healthy metabolism. So resmetirom kind of, in a way, treats hypothyroidism in the liver. It reduces triglycerides accumulation and therefore reduces steatohepatitis and remarkably improves fibrosis. So this is something that is readily available to our patients. So in conclusion, we're back to our advanced fibrosis management, and now we do have treatment in addition to lifestyle modifications for these patients. So this is exciting. And I certainly hope that in primary care setting, we can also consider in pharmacological management and use it for at least patients in the intermediate risk category without necessarily waiting, 6 months to a year for hepatology referral. So take home points. Steatotic liver disease now has new nomenclature. AASLD guidelines now offer an algorithm for diagnosis and treatment of steatotic liver disease, both in primary care and in advanced practice. We should remember about synergistic effects of alcohol in steatotic liver disease and, treat patients with MET ALD accordingly. We have a comprehensive way to treat these patients, and disease-modifying liver drugs are here. And that's it for me. Thank you so much.
Thank you, Dr. Reutemann. I feel like these talks always make us reflect on our own liver rounds that we may or may not have had at some point in our lives. But thank you again to both speakers. We will now open the floor up to questions. Let's start with on the left or your right.
Yeah, I get Dr. Gish's little emails all the time. And one of the things he always recommended, all cirrhotics should be on statins. And the statin data looks pretty good on liver cancer for cirrhotics, but also on portal hypertension. And it's kind of a poor man's liver disease drug. I mean, do you recommend it? Certainly it's going to cost less than the $100,000 a year these new drugs are going to cost for fatty liver disease.
Yeah, so we we love statins, and certainly in patients with MASLD or MET-ALD, who by definition have metabolic risk factors. One of those is probably dyslipidemia. We encourage patients to be on statins. I have literally my dot phrase for treating patients with MASLD. I have a dyslipidemia set which specifically says statins are safe and effective in treating patients with metabolic risk factors and fatty liver disease, because I think the concern in a primary care setting is that, statins can affect the liver, we should stop the statin and let the liver disease people take over. But we really should be encouraging patients who generally almost all of our patients with MASLD have indications for statin to be on a statin.
But his implication was that even in non-NAFLD, I mean, if you just have your alcoholic cirrhotics in terms of the hepatocellular cancer risk, and I thought I saw some stuff that it actually may be useful after variceal bleeding, that just cirrhosis in general, that there's something beneficial about statins independent of the effect on fatty liver.
Yeah, there are large population studies looking at the effects of statins and also aspirin on certain types of liver disease, including HCC. They are not part of our guidelines yet. I think with these large population-based studies, it's hard to tell correlation and causation. And so I don't think that we are necessarily starting patients on a statin who do not have indications for a statin in general. But as I said, a lot of our patients already do. And so in those patients, I'm very encouraging of either remaining on a statin or starting a statin.
And just one more quick question about portal hypertension. The portal vein diameter over 12, is that highly predictive of portal hypertension if you don't have access to the liver imaging stiffness stuff? I mean, can you just use the portal vein at 12 and platelet under 150,000? Can you basically assume they have portal hypertension?
I have actually had lots of patients without liver disease referred to me for a dilated portal vein, and it's very tricky in the absence of other signs of portal hypertension. Obviously, it's suggestive, and certainly there are other radiographic signs of portal hypertension that can, if somebody has a large spleen, low platelet count, and ascites, you don't need to think they have portal hypertension. I don't think that just a dilated portal vein is enough evidence of clinically significant portal hypertension, though.
Thank you.
I just want to add a couple things. We certainly do need to encourage patients to be on statins, but I think, even more than that, we need to encourage providers to continue statins on patients who need them. I mean, I see it over and over again that, patients' liver enzymes are elevated, therefore the statins were stopped. So all of you here, please don't do that. It's very, very safe and it's part of the treatment for steatotic liver disease and metabolic syndrome. The other thing, to answer your questions about statins outside of the indication, is we also have to think about the pill burden for our patients. A lot of patients with advanced liver disease are also already taking a lot of medication. So I do want us to be judicious in prescribing the things that are truly, truly needed for them.
Dr. Wong.
Thanks, Marina. Wonderful talk. I have two-part question. The first question is, it's very exciting. We have resmetirom available now. What is your approach in using resmetirom in patients or in combination with GLP-1s? It's not approved, but it's approved for obesity, diabetes, and clearly shows some signal for NASH resolution and maybe fibrosis. So first part is your approach to using those in addition to GLP-1s. And then second part, a little bit trickier. I don't remember in the Maestro trial what the cutoffs were for alcohol use, but so many of our patients, if you ask, actually have met ALD. So I wonder how you think the real world efficacy of resmetirom will be in patients that actually have more of a met ALD versus a true pure MASH presentation.
Absolutely. I think I'll start with the second question. I think most of our patients, if we take a good enough history and have good enough trust with our patients, are met ALD patients. There are very few that are going to fall into either one of the, true buckets outside of that. So I want to encourage you to use disease-modifying drugs for the liver for patients with met ALD. And I do think, and I do hope that the real-world data will prove this approach correctly. In terms of the GLP-1s and resmetirom, I think it's a great combination. And I think similar to hepatitis C, the future of treating MASLD is in drug combination. And I think this, if I had a crystal ball, I think this is probably going to be one of the more promising combos. So I do use it and I do encourage the use of it.
Thank you.
Okay. In the interest of time, I think we will take a break. If anyone has further questions, please feel free to come up. Thank you again, Dr. Lee, Dr. Reutemann. And also one more quick thing, please take a look at the posters and submit your People's Choice Award at some point during this break. So hopefully we can announce the winner later today. Thank you.
Okay, it's 11:05, we're on the last stretch. And the next topic is going to be done by a good friend of mine, Dr. Neil Stallman. The name of the topic is Rapid Fire Updates from Recent ACG Guidelines. Dr. Stallman is a very modest young man. He doesn't like anybody to talk to him much, but he was born in the city where I was supposed to land in 1990, but by some kind of fortune, I ended up being in California. We're talking about New York City. He got his education, he got his life together, and finally he ended up being in the Bay Area, right? Same thing that happened to me in 1990 in the Bay Area, 1990 in the Bay Area. And he is the man who cannot say no to anybody. So he is a chairman of the board of governors, the American College of Gastroenterology. And because of that, because he cannot say no to anybody, he's a prolific writer, educator, and he also clinical professor of medicine at UCSF, but his passion is taking care of the patients, and he works in Oakland. You can see that on the screens, right? I can tell you one little thing. The person can be brilliant, can have a brilliant mind, but does not mean that they are brilliant speakers, right? This young man, he got both things together. He put check mark to both boxes, okay? And I always looking forward to hear him because when he talks, I mean, it's an amazing moment in my life, okay? Without further ado.
Thank you, buddy.
You know that like I'm torn right now between, that's so kind. I'm neither young nor humble at all. But with that setup, like now I have to deliver. It was a lot easier if you had very low expectations, Michael. Thank you. Now I'll have to be good, damn it. Notice the title of this talk. So I talk at this meeting a lot because you guys let me. So thank you for keep coming back. And if you've heard me speak before, you know I do speak rapidly. And I've literally titled this a rapid talk. It's going to be a rapid talk. So get used to that. You are going to get handouts. I just found this. You will have access to these lectures. So we have to clean them up a little bit and make them formatted better for you, but you will have access to every one of these slides that's going to be here. So if I'm going fast, and I'm going fast, it's all, you have it. You can look at it. You can read it on your own. There's my disclosures. So the ask this year was, well, you're an ACG guy. Let's talk about sort of the guidelines. And I've written a bunch of guidelines. Let's talk about what's new guidelines. So I went through what's come up recently, and these are kind of the last 6 that we've put out. And you can see I've kicked out constipation because we had an exceptionally cool talk yesterday about constipation. So I had nothing else to add on that one. Thank you, Dr. Nishadian. And of course, we just had 2 really good talks on alcohol-related liver disease as well. So I get off the hook on those 2. So I'm not going to talk about either of those. I am going to talk about these 4: pancreatitis, lower GI bleeding, celiac disease, and C. diff, of course, which is the one that's probably most to my career. Pancreatitis is the long one. So as you're going through and you're thinking, my God, is this ever going to end? It gets better. It gets faster. So these come out of the guidelines. I'm not going to read these to you. That's not my intent. I put these in so that they're in your handout so you can look at them. And you'll see that the guidelines all have the same kind of graphic format. And we really have 2 things we talk about. We talk about formal recommendations, and those recommendations are under what we call a grade methodology, a kind of very rigorous methodologic, say to what does the data say? And then you can make a recommendation that's a strong recommendation or a, quote, conditional recommendation. And then you say, well, how good is the evidence for that? And I just want to highlight that, do I have a pointer here? I do. I just want to highlight that most of these recommendations are conditional, and that's just a fact in this world. If you're going to impose, in the old days, guidelines, and I wrote some of them, were like, here's what a bunch of old men in a room think. And that's not a good basis for a guideline. So this is smart people saying, what does the data say? But if you instill that threshold on guidelines, you're not going to be able to say as much as you think because the data doesn't answer a lot of our questions. So in a lot of cases here, we don't have good data, and the recommendation has a very low quality of evidence and is very conditional. In fact, in this particular section, the only strong one is for rectal indomethacin that I'll mention for preventing post-ERCP pancreatitis. That is literally the only strong recommendation we're making here. The other thing that happens when you make guidelines rigorous is that there's just not data to answer a lot of questions, but a bunch of smart people have thoughts on this. So then we came up with this concept of key concepts. And key concepts are, again, sort of what a bunch of people in a room think is good practice, but they are not evidence-based. They're not driven by science and studies. We can't score them or grade them. This is expert consensus. Consider it that. So there's a bunch of those as well. There's sort of formal recommendations and expert consensus. And what I'm going to do for these next 4, by the way, is just give you the greatest hits. I'm going to give you the 6, 8, 10 things that I think matter. There's 20 things there or 30 things there, but most of them are not immediately relevant. And I'm also going to talk more about things I think that change how I practiced. Michael called me young. I'm not young anymore. I'm old. And I've seen some of these things change. And for example, the first one here, CAT scans. You couldn't come through my ER and not get a CAT scan with belly pain, and probably you still can't for various reasons. But the guidelines say pretty clearly, you don't need a CAT scan to make the diagnosis of acute pancreatitis. You don't. You should use CAT scans in a couple of scenarios. You should use it if you don't know what's going on, so you need it for a diagnostic, or if your patient's not doing well and you're trying to kind of risk stratify and prognosticate them to necrosing or non-necrotizing pancreatitis, because that's a useful discrimination point. The guidelines are very pro, though, for ultrasound, right? Their ultrasounds are having more role in IBD. They're having more role here. There's no radiation. They're not going to hurt the pancreas. And by the way, there is a iffy data that early CAT scans may have a non-beneficial effect on the pancreas in animal models, not in humans. Contrast, rapid contrast in a hypovolemic animal with an animal model of pancreatitis can hurt the pancreas, actually. And so that's part of the reason for a reticence with CAT scans. But ultrasounds, of course, have no risk. We're getting better and better at them. And the key question in a patient with acute pancreatitis is biliary or not biliary. That's really your dividing line. And ultrasound's a really good test for that. You should do it. And in fact, they even say, if you're not sure and they have overlying bowel gas and all the other nonsense you see, do it again, basically. So less CTs, more ultrasound. And the final thing they say on imaging is if you don't know why someone has pancreatitis, they're not an obvious drinker, they don't have gallstones, they need cross-sectional imaging of their pancreas to look for structural pathology in their pancreas, cancer, divisum, things like that, cysts and things like that. So that's the imaging piece. You know, I grew up with the Ranson criteria. In fact, I trained at NYU a million years ago where Ranson was a surgeon. And the whole point of, in the guidelines anyways, like none of these scoring systems are great. They all have pluses and minuses. It depends on how you measure them and when you measure them. And they tried to simplify it a little bit and pretty much said, here's really 4 big risk factors. Your BUN is up, your hematocrit is up, your hemoconcentrated, obesity and SIRS are in a very simplistic way, markers of bad outcomes without pulling out a calculator, basically. I'd also mentioned idiopathic before. The other thing to do if you don't know why someone has pancreatitis, on their admit labs, you basically check a triglyceride, and a triglyceride of over 1,000 is felt to be a potential etiology for pancreatitis. I said already consider pancreas cancer with imaging. And then there's the question in acute pancreatitis. Well, if you don't know what went on, could it be microlithiasis? Could it be baby stones or sludge that we're not seeing? And in the old days, we would sometimes aspirate and get crystals and look for crystals. It's an ERCP. It has risks. You're taking someone who had pancreatitis and putting a catheter in their duct. That's not a great idea. Basically, now the guidelines say if you have 2 attacks and you're a surgical candidate and you don't know why someone had pancreatitis, it is reasonable to have a conversation about an empiric cholecystectomy in that population. It is a reason. That's not to say everyone should get one, but that's a conversation to have after your second attack of unexplained acute pancreatitis. Fluids. You youngsters are probably better at this than we are, but if you're older like me, you've watched fluids ebb and flow, haha, pun unintended. So when I was younger, we didn't give a lot of fluids, and then you're probably aware 10, 20 years ago, the only treatment of acute pancreatitis was to flood them, to give them insane amounts of fluid. And then, of course, we got some data that said, yeah, that may be a little bit too much, including the Waterfall trial and some other data that dialed it back a little bit. So we went from low fluids to insane fluids, and now we're at moderately aggressive fluid. So that is where we've settled down in a recommendation to you. Ringer's lactate is better, and the data is fairly consistent. It's a little bit controversial and not a perfect answer, but most of the guidelines, including this one, suggest that Ringer's is a better hydration solution for you than normal saline. Hydration remains important, particularly early on, and there's a nice graphic showing that in edematous pancreatitis, your fluid is extravasating. You are weeping into your belly. That leads to low perfusion of your pancreas, and that, of course, leads to ischemia and necrosis of your pancreas. And in the very simplistic sense, necrotizing pancreatitis, really bad. Non-necrotizing pancreatitis, not so bad. It's really almost that straightforward. So we should be trying to prevent that. And fluid does that. And your goal is to drop the BUN, basically, is to just drop their creatinine as well, but essentially just hydrate them. The role of ERCP is evolving also. We are doing less for good reason. So we used to do diagnostic ERCPs in these people. You don't need to do a diagnostic ERCP anymore. You can get an MRI or an EUS, depending on what you have available to you, to decide if someone has a need for a biliary intervention. And the large majority of our ERCPs today should be interventional ERCPs in someone that we've confirmed needs it, basically. We talk about early ERCP. Early ERCP is 24 hours. It's not 2 in the morning when you get called from the ER with your cholangitis patient. You can wait until you have a team and a staff and the sun rises, and everything can happen in a relatively rational way. Rectal indomethacin is the damnedest thing because it's really got, I told you it's the only strong recommendation here. It literally is. The data is super strong. It works. And we still don't do it very well. There's now all these studies looking at who gets, what percentage of people getting ERCPs are getting rectal indomethacin. It's still far too few. It should be standard of care. And the guideline says it's standard of care in those at high risk for post-ERCP pancreatitis. But then in the body, I literally quoted them, if you're considering the cost, the risks, and the benefits, you should give it to everybody. It's literally popping a suppository in their tush when they're on a table and asleep. You don't even have to do it for them while they're awake. So rectal indomethacin, and they also say basically peri-procedural hydration should be standard in all ERCP patients in this case. They do suggest a pancreatic duct stent in those people. I do a lot of work on using less antibiotics. We're not going to talk about diverticulitis today, but one of my mantras there is use less antibiotics. This is another place where we should be using less antibiotics. We overuse antibiotics in general. We've historically overused them in acute pancreatitis. People come in and they're sick. They look like their white count is up. They're tacky. They're hypotensive. They look like shit. So of course, what we do, we give them antibiotics. Wrong. We are not helping those people. The guidelines are very clear that you should not be giving prophylactic antibiotics in acute pancreatitis unless you know somebody has an infection. The other thing that's changing from my youth is we stick less needles in people than we used to. We used to do a lot of FNAs. When you suspect necrosis, you're 5 days in, you're 7 days in, your patient is crashing. What I was trained to do was stick a needle in and define whether or not they have infected necrosis. The guidelines now say the yield of that is low. There is some risk of complication. Just treat them. So essentially, empiric treatment now of later on suspected infected necrosis, different than upfront prophylactic treatment, it is recommended. Remember, you have to use antibiotics that penetrate the pancreas. Imipenem is the one that's used mostly in my center. Not all antibiotics will penetrate a hypoperfused, ischemic, or necrotizing pancreas. You want to really avoid intervention in these people early. You want to let these people heal, the wall of their cysts and things to heal. So we try not to go in and debride them either endoscopically or surgically. If we can, we want to wait to do that. And I think that's on my next slide for surgery too. And then the other thing is we often in my hospital, we still do this. I see the intensivist giving empiric antifungals in this population for putative fungal, hyperinfection. No, the guidelines are very clear not to do that. Feeding is much earlier. So again, I grew up in a world where we didn't feed these people and then we kept them NPO and then we kind of gingerly gave them clears and then we advanced as tolerated. The guidelines are absolutely not. Early oral feeds, even within 24 hours, you can go straight to a low-fat, solid diet. You don't have to do this whole thing. And we want intragastric feeding. We do not want enteral feeding. There's very few scenarios for parenteral nutrition, rather, in acute pancreatitis. We want enteral feeding. We also want gastric feeding. We used to be worried, tremendously worried, if we put a high-fat meal in the stomach, you're going to turn on the pancreas, you're going to worsen their pancreatitis. So let's spend days trying to get a tube way past the pylorus. And then, of course, they fall back. They last, an hour there. And we used to do these. We pass them, and unless you clip them in, they come back. Nonsense. We don't have to do that anymore. Feed them. It's just okay. NG tubes are acceptable. That is in the guidelines. Surgery, 2 key pearls, and we'll move on from pancreatitis, I think. One is if they do have biliary pancreatitis, you should take out their gallbladder before they go home. That is sort of standard. There may be exceptions to that for why someone wants to go home and come back. It's not sort of required, but the guidelines are pretty aggressive. If you got admitted with biliary pancreatitis, don't send that patient home with their gallbladder or they're at risk for doing it again, and they're going to feel bad and you're going to feel bad. And then, of course, if they have necrosis and you have to debride them, wait and wait and wait. Don't let your interventional endoscopist in yet. Don't let your surgeons in yet. You want this to mature as much as possible unless they're like septic and sick. So if you think they have really aggressive sepsis syndrome from infected necrosis, you got to do it, but we want to try to avoid it. All right, that's the pancreatitis piece. I told you it was going to be fast, and I told you that was the longest. Lower GI bleeding has a whole lot of words up there that'll be in your handout, but I'm going to simplify that and say far fewer of those words for you. Another thing I'm learning, scoring systems, the Oakland score, which sadly is not named for my hometown in Oakland. It's actually named for a Dr. Oakland in England, a woman doctor in England named Catherine Oakland. She has come up with a somewhat better prognostic score for lower GI bleeding. You can find all of these on MedCalcs or MDCalcs, which is actually a very useful site for scoring any of these things, MELDS and Lilly scores, whatever. The mdcalc.com is a good site. And this one is really useful for ERs, not so much for you, for sending people home. If they have an Oakland score of less than 8, they should be a candidate for discharge, and that I think is a useful way to think of that. We're transfusing less, as you know, right? We used to want to keep these people over 9 or 10, not anymore. We like to let them be a little bit on the low side. We are not over transfusing people unless they're obviously hypovolemic and shocky or have underlying critical coronary disease. And yes, in that patient, you're probably going to keep their hemoglobin higher. But for most people, it's the suggested threshold for most patients is now 7. Platelets over 50. Basically, if you're going in to do intervention, you'd like a platelet count of over 50, but they're also don't routinely give someone platelets just because they're bleeding. So the guidelines argue against that. If you're on aspirin for therapeutic reasons, secondary aspirin, continue their aspirin, which doesn't happen a lot. And the hospital is to admit these patients stop their aspirin, but not if it's actually therapeutic aspirin. If it's prophylactic aspirin or primary aspirin, meaning you're just taking it for prevention, yes, that's an elective med, prophylactic aspirin, prophylactic NSAIDs. Of course, you should stop them. But therapeutic aspirin, you should continue on. And in fact, you should probably continue antiplatelet agents if people have fresh stents in them as well. So I think we're a little fearful sometimes in doing that, but it's the right thing to do. The other thing in my old days is we wouldn't scope people unless we got their INR really low and they normalized their INR. And we would use that as a kind of excuse. Well, I can't fix it because they're coagulopathic. And the guidelines like, yeah, you can actually still fix it below 2.5. So we've lost a little bit of our, I'm not fixing this until you fix their INR. 2.5 is the number they're working on. They don't recommend these reversals like tranexamic acid, but they do recommend basically PCC in patients on oral anticoagulants who are bleeding. So if you're coming in with a bleed and you're on an oral agent, PCC is better than FFP, basically. CTAs are good now, right? That's helped us a lot. In the old days, we had this algorithm of nuclear scans and angios, and none of those worked very well. CTA has been actually a really nice advance, and it is your first best test. And if it's positive, it's pretty binary. It either drives you to a colonoscopy or it drives you to IR. And they're both acceptable options depending on where you practice and who you got. In my hospital, we do colonoscopies. We come in, but there are places that don't have a IR doc on call, or there are places that may not have a GI on call. So you're allowed to go either way. Clearly, you want to, of course, prep them. We'll talk about that. You want to IV resuscitate them like your pancreatitis patient as well. They need fluids. The decision tree on an upper endoscopy and a lower GI bleeder is a hard one. And we used to talk about NG tubes and BUN and creatinine ratios. And the guidelines make the point that they're not as good as you think. And if you're worried, you're going to have to look. And sometimes you look and you're going to do negative uppers. I had one this week in the hospital, actually. You're going to do, who was a surprising upper. We thought he was a lower and was sort of a surprising upper. And where the cut line is for that, I can't tell you, but you have to constantly kind of keep that in your mind. If someone's coming in with a lower GI bleed, for most of them, they should get scoped. They don't get scoped emergently. They don't get scoped at 2 in the morning, although my ER doesn't understand that yet, so they still feel the need to tell me about this patient, just so you know, at 2 in the morning. Great, I know, thank you. But I'm not scoping anybody at 2 in the morning, and I'm not scoping anyone unprepped ever. That is not what we do in this world anyway. We do not do unprepped colonoscopies. You have time, prep them, take a deep breath. Urgent or emergent colonoscopies are not recommended. In fact, the guidelines overtly say don't do that. So it's not even, you're not even off the hook. It's bad care to do that. You should not be doing them that early. They talk about treatment, and if you have diverticular bleeding, which is probably the most common cause of these patients, they basically say do something, and they don't tell you what the something is. You can use clips, you can use bands, you can use cautery, based on what you're good at, basically. What they do say, though, if you have a post-polypectomy bleed, clips are the standard of care for that, and if you have an AVM bleed, APC is the standard of care for that. So other bleeds, diverticular bleeds, do what you're good at, but if it's a post-polypectomy bleed, you probably want to clip them. Observation is okay. We all see these patients who come in with recurrent diverticular bleeding, and the guidelines are clear. If they've been scoped in a year and you know what they got and it's behaving the same way, you don't have to do that patient 6 times. You can be selective about that patient. But if they're not that patient, they should get a colonoscopy before they go home to look at what they have, basically. As I said, stop preventative aspirin and NSAIDs, but don't stop therapeutic aspirin or indicated aspirin. And again, resume their OACs earlier than I think we used to. Again, we used to be more fearful. They'd call and say, when do you have to restart it? We'd say a week or 2 weeks or something, because that's the window of rebleeding. All of the data suggests sooner is better. It's our paranoia because we have to deal with the fact if they bleed, but in fact, if you measure their outcomes, their thromboembolic outcomes are far preferable by resuming their agents. All right, that's lower GI bleeding. We get on to celiac. This is again not something I'm going to take you through, but you now probably know this. They want biopsies from both the bulb and the second portion, sort of the superior aspect of the distal bulb, and as far down kind of as you could get. There's a list there of things to consider testing for celiac. I will highlight it only to tell you that if you're a gastroenterology provider, you have never seen a patient that doesn't have one of those things ever. Bloating, fatigue, dyspepsia, being a man is probably enough. Constipation is one of them. So they literally say in any of these situations, consider celiac disease. I challenge you to find a patient that doesn't have any of these considerations. Endoscopy is standard of care. In kids, they sometimes talk about not scoping people for good reasons. And they say that, well, if you're not going to scope for some reason, a really high TTG-IgA and an EMA, an anti-endomysial antibody, is good enough if you're not going to do endoscopy, but you should do endoscopy. Seeing lymphocytes in the duodenum is not enough to make the diagnosis of celiac. You need villus atrophy as well to see that. The guidelines overtly suggest intestinal healing as an endpoint, and they say do another endoscopy in 2 years. I find that an extraordinarily arbitrary recommendation. Is it 6 months or 12 months or 2 years? I don't know, but that's what they've told you. Or if they're not getting better, right? That's the other reason to do an endoscopy, if they're not responding to something. There's a new world of home gluten detection devices. So your celiac patients can spend too much money on, in addition to the Great Smoky Mountain doctor's labs nonsense, they can spend too much money on home gluten devices. The guidelines say, nope, they're not yet ready for prime time, and we do not advise that. So medically, we don't think that's a good thing. The thing they do advise, and I'm really glad they do, like in IBD and like in other things, the standard of care should be consultation with a dietitian who has a skill set with gluten-free diets and celiac disease. And the biggest problem, as you know, is getting insurance to pay for that. So more and more guidelines that say you have to see a dietitian is a good thing. I do some biome stuff. Dysbiosis occurs in celiac disease. There's not good data to suggest that it's causal rather than consequence. It may well be consequence. There's a little bit of a debate in the celiac world on oats and gluten-free oats. And can you get gluten-free oats? And different manufacturers, there may be immunogenic in some. And so if your patient's having oats, you're supposed to follow them, and you're supposed to give them all pneumococcal vaccine. That is now standard for your celiac patients. Okay, and I'm going to finish up with the last guideline, which I missed one. I wanted to embarrass Robert Wong. He was the author of that lower GI bleeding guideline, by the way. Are you here, Robert? No, I can't embarrass him. He's not even here. Here he is. Robert was the author of that one of the authors of that lower GI bleeding guideline. I even put you in yellow, and I forgot to see it because you can't see it from here. I was the author of one of these guidelines. So this particular one, C. diff infection. Of course, the best way to treat C. diff is not let someone get C. diff, and the best way to not get C. diff, of course, is to give people less antibiotics. And we, again, radically overuse antibiotics in this country. There's huge data to that point. When someone has C. diff, you want to isolate them until their diarrhea gets better. You know, we hand this off person to person. So gloves are really important. Alcohol-based hand sanitizers are not really important or very effective in C. diff transmission. Soap and water and gloves work very, very well. We do not overtly recommend any probiotic regimen for patients with C. diff. There's some little bit of data on S. boulardii, which is a yeast, not a bacteria, marketed as Florastor, and there's some moderate data that has a role, but the data for probiotics in either the prevention or treatment of C. diff are pretty poor. There is data that PPIs are a risk factor for C. diff and recurrent C. diff. It's real data, and if your patient's on a PPI for no good reason, they shouldn't be, and you should stop it. If they're on it because they have Barrett's or a stricture, well, they need it and they should stay on it. But if they don't need it, they shouldn't stay on it. If you have mild to moderate C. diff, you can have your choice of Vanco, Fidax, or metronidazole. If you have severe C. diff, you can't have metronidazole anymore. You have to have Vanco or fidaxomicin. Those are the two standard treatments for that. If you have fulminant C. diff, you should have IV metronidazole. You should have higher dose oral vancomycin. Although let me tell you, the data that supports Vanco 500 versus Vanco 125 is zero. It's total. We think it's a good idea, so we should do it. Your patient is sick, give them more Vanco. And that the science behind that is exactly zero. If they have an ileus, rectal Vanco enemas are helpful. And now more and more FMT is actually quite helpful in in fulminant C. diff infection. For recurrent infection, different than fulminant infection, fidaxomicin or a tapering pulse dose of vancomycin. Bezlotoxumab is marketed as something called Zimplava. It's an IV infusion of anti-C. diff toxin antibodies. It lowers recurrence rates by about 50%, which is reasonable. But to give you context for that, it's from 30% to 15%. It is not a radical impact, but it is a moderate impact. I use it in older people. Those are the ones who need it, and we are aggressive about suggesting it in those people. We sometimes use prophylactic vancomycin. We even have a name for it now. We call it OVP, or oral vancomycin prophylaxis, which is you have a patient who gets UTIs and she's on her third attack or fourth attack because she keeps getting Cipro for her next darn UTI. Concomitant use of vancomycin is reasonable. There's a trial underway to know if that's going to work or not. I can't tell you that yet, but we do it and it works. As you know, we now have 2 approved products, and I'm going to talk about them. There are 2 more coming, but one of them is called Rebyota, or live JSLM. The FDA had to create a new class for these drugs. We don't have these drugs before. They're called LBPs, live biotherapeutic products. That's literally a new FDA designation, LBPs, and you have 2 of them. This is Rebyota. It is an enema of whole human stool. It is natural human stool in an enema bag that you give via an enema, and you put the patient on their side and you give it one time, and this is the outcome: a drop from 70% to about 57%. So a decrease. That was enough to get FDA approval. It is not dramatic, but it is effective. The other are these spores called live BRPK, also sold as Vowst. And these are purified spores. They're not whole stool. They're a subset of Firmicutes spores. They're given as 12 pills over 3 days. This one requires a mag citrate flush beforehand, just to get rid of the antibiotics. That's why we're doing that. We're trying to get rid of any residual antibiotic. And this is their data, which made the New England Journal, actually, because it's good data. It dropped recurrence rates from 40% in that population to 12%. A pretty significant risk reduction. So that is a reasonable agent. I'm just putting in a shameless plug for this document, which I just had the privilege of editing, and I got 16 really smart people to write 8 chapters on really cool things about the biome. It's still up to date. It won't be up to date in 6 months or 12 months because this moves really fast, but it's a great document if you're an ACG member, and if you can get it online for free. If you're not, it was mailed to you, actually. If you're not an ACG member, you got to talk to me about that. And this is, I think, my last slide, so I'll finish here. The AGA just put out a new guideline, and that really wasn't my talk today. It's not radically different, basically. They're moving FMT earlier now. So if you have a high-risk patient, the prior guidelines say do it after your second recurrence. It is now acceptable to do it after your first recurrence or your second attack. And the guidelines talk about the difference between what they call traditional FMP, which is stool, basically, an open biome, and the model we've used for years, which is appropriate in immunocompromised people. And they actually overtly discuss or recommend against using FMT in IBD or IBS, basically. There's no role. We are still in a world of FMT for recurrent C. diff. That is still the only indication for that. All right, that's it. I'm out of breath. I'm going to stop. I'm going to be around for questions later. I'm sorry if I ran over. Michael, thank you. Thank you, guys.
Quite amazing, right? So the next speaker is Christina Chow, and Christina is a full-time faculty member and Associate Division Chief of Gastroenterology and Hepatology at Highland Hospital, part of the Alameda Health System. She received her medical degree from the Case Western Reserve University School of Medicine and did her hepatology and fellowship at Stanford University, followed by the GI fellowship at CPMC, California Pacific Medical Center. She serves as core faculty and the director of the GI education for the Highland Hospital Internal Medicine Residency and the director of outreach for the CPMC's GI fellowship. Her interests include gastrointestinal motility disorders, hepatology, and medical education. And we will be speaking today on PPI versus the PCAB, what's new in the management of the GERD and H. pylori. Please.
So, hold on, sorry. Yeah, so thank you for that kind introduction. I will be talking about potassium competitive acid blockers, or PCABs. And I figured that this is something we will be seeing more so and more often, and another option that we have other than PPIs. So I have no financial disclosures. Okay. So this is my outline. In order to understand PCABs, I do think we need a brief review of how PPIs work. So we'll start with PPI versus PCABs, including understanding the mechanism of action along with the pharmacodynamics and pharmacokinetics, its use in currently approved FDA indications for erosive esophagitis and also H. pylori treatment, briefly on its use in non-erosive GERD, which is not yet approved, although it's undergoing evaluation, its safety profile and dosing, and ultimately take-home points. Okay, so PPIs, as we know, it's first introduced in the 1980s and is commonly used for acid-related disorders and disease. It irreversibly inhibits the hydrogen potassium ATPase, and it's been used for more than a quarter century as first-line treatment. But however, despite that, we know that there are areas that can be improved. So one of the things is it takes several days to show maximal effect because they only bind to activated proton pumps. It also has a short half-life of 1 to 2 hours and need preprandial dosing for optimal effects. It's acid labile and requires enteric coating, which leads to its delayed onset of action. Effects of PPI are influenced by cytochrome P450 CYP2C19 polymorphism, where Asians are more so poor metabolizers, 12 to 23%, versus 2 to 5% in Caucasians. And therefore, we see higher eradication rates with H. pylori in Asian studies, and also higher effectiveness of PI in Asians. And its effects are not satisfactory, leading to addition of H2 blockers at night. So to overcome the issues with PPIs mentioned earlier, alternative formulations of conventional PPIs and new hydrogen potassium ATPase inhibitors were looked at and established. So this was developed in the 1990s, the PCABs, but it rapidly, effectively, and reversibly inhibits the proton pump. So some of them include rivaroxaban, which has been approved in South Korea and India in 2007, vonoprazan that has been marketed in Japan since 2015, and it's also available in the Philippines, Singapore, Thailand, and tegoprazan that has been marketed in South Korea in July of 2018. So you can see that some of these PCABs have actually been around for quite some time already. So how does it work? So I want you to first focus on your left side. So that's the mechanism of action for PPIs. So proton pumps are stored in tubular vesicles in the cytoplasm in an inactive state. And you see with the inactive states, that's the, hold on, this gray tube here. So that's the inactive state. And activation of the pumps occur after their insertion into the extracytoplasmic secretory canalicular membrane at the luminal border. And once they're active, you see them now as this blue one here, right there. So PPIs are prodrugs that are converted to sulfonamides, which covalently bind to cysteines on the active proton pumps, so the blue ones, blocking exchange of hydrogen and potassium ions. And PPIs require an acidic environment for activation, and because the extracytoplasmic secretory canaliculus is acidic, that's basically the site of PPI accumulation and activation. And you can see the PPI by this red spot here. So that's the PPI. Now let's focus on your right side. So your right side is actually the PCAB, which is identified in green. And so PCAB accumulation and binding are not pH dependent, and therefore it allows it to bind to both inactive, so the gray one, and also the active proton pumps in the cytoplasmic and also in the extracytoplasmic locations respectively. And PCABs act through ionic reversible binding, competing with luminopotassium ions that are necessary for hydrogen exchange by blocking access of potassium ions to the potassium binding site. Okay. So I do have to say pharmacokinetics and pharmacodynamics was not my favorite subject in medical school, but I do think that we need to look at it in order to understand how this medication works. So given that it is already approved in Japan and other Asian countries, there were no prior studies that provided comparative pharmacodynamic data for vonoprazan and PPI in the Western population. So the aim of this study, it was a randomized crossover study assessing pharmacodynamics and pharmacokinetics of vonoprazan and lansoprazole in healthy U.S. subjects. So everyone was randomized to a 1-to-1 trial. So they either got vonoprazan 20 milligrams daily for 7 days, followed by a 7-day washout, then PPI daily, which was lansoprazole, 30 milligrams daily for another 7 days, versus the other one where they got PPI first, followed by, again, that 7-day washout interval, and then followed by vonoprazan. Everyone had to fast overnight. Everyone had to take their medications at the right time, and also the meals were all standardized too. And basically, the intragastric pH was recorded continuously the day before the test. So you have a baseline, and then on days 1 and day 7. And you can see here, looking at the day 1 figure, so the gray at the bottom is the baseline, the blue is lansoprazole, and the yellow is vonoprazan. And you can see that, just at the initial 0 to 2 hours, you see that the slope of vonoprazan and PPI are similar. However, at around 2.5 hours, you see this takeoff of vonoprazan, the yellow line, going all the way up. And if you look at hours 12 to 24, so the second half of the figure, which is basically measuring, nocturnal symptoms, you see that vonoprazan stayed almost consistently above 4 with a slight dip in there, whereas with PPI, which is the blue graph, it does definitely dip down with that nocturnal findings that we see. And with day 7, you can see that vonoprazan, again, the yellow line stayed consistently above 4, whereas lansoprazole improved. However, you still have that nocturnal dip. And then looking at the pH greater than 4, so basically that is the holding time ratio, which is represented by the percent of time where the pH is above a certain threshold. So for 4, you could see that by day 7, vonoprazan was 87.8 versus lansoprazole of 42.3. And then for day 6, you see that vonoprazan, or for pH of greater than 6, you see that for day 7, vonoprazan was 62.5 versus lansoprazole of 16.4. And the reason why we care about these pH values is that we know that, you need a pH of greater than 3, which is needed for ulcer healing, pH of greater than 4 needed for reflux esophagitis, and a pH of greater than 6 that's needed for cure of H. pylori and prevention of rebleeding after endoscopic hemostasis. Okay, so vonoprazan provided significantly more potent inhibition of intragastric acidity than lansoprazole in healthy U.S. subjects. The proportion of 24-hour period during which intragastric pH was greater than 4 was nearly 3-fold higher with vonoprazan than lansoprazole after a single dose, and approximately 2-fold higher on day 7. Differences in reduction of intragastric acidity were maintained throughout the 24-hour period, and especially looking at the nocturnal ones, you can see that it was consistently above 4 in the PCAB group. And the longer half-life of vonoprazan in the study, it was 7.9 hours versus lansoprazole of 1.4 hours, helps account for this longer duration of gastric acid inhibition. So the summary is that vonoprazan provided more rapid, more potent, and also prolonged inhibition of intragastric acidity than lansoprazole in healthy H. pylori negative subjects from United States. Okay, so this is a summary slide comparing PPIs and PCABs. So for PPIs, we know that it's a prodrug, whereas PCAB is not. PPI is not acid stable, although PCABs is acid stable. PPI inhibition is irreversible. PCABs is reversible. We know this that maximum acid suppression after dosing for PPI takes 3 to 5 days, whereas for PCABs it takes 1 day. Half-life of PPI is 1 to 2 hours, whereas for PCABs is anywhere from 6 to 9 hours, depending on what type. And for vonoprazan in the study, it was 7.9 hours. PPIs are affected by CYP2C19 polymorphism, whereas PCABs is not affected. And optimal dosing for a PPI is 30 to 60 minutes prior to meal times, again, related to its half-life, whereas for PCAB, you can take it anytime independent of meal times due to its longer half-life. Okay. So currently, vonoprazan is the FDA-approved PCAB in the United States, and the approval was obtained in November of 2023. And the indications include treatment of erosive esophagitis and also treatment of H. pylori. Worldwide indications also include gastric and duodenal ulcers, healing of reflux esophagitis, and gastric and duodenal ulcers, healing of reflux esophagitis and prevention from relapse, secondary prevention of low-dose aspirin or NSAIDs-induced gastric mucosal damage, and also H. pylori treatment. Okay, so we'll now talk about its use in erosive esophagitis. Okay, so although PPIs are effective for healing erosive esophagitis, we know that some patients do not achieve success with conventional PPI treatment. And lack of healing of erosive esophagitis with 8 weeks of PPI therapy can be seen in 5 to 20% of patients, although rates of up to 30% has been reported in patients with the more severe esophagitis. And because Asian and Western populations differ in factors that may influence acid inhibition, assessment of PCAB efficacy in Western subjects is important. And so this study by Lane was a randomized, double-blind, parallel group trial in which 2 doses of vonoprazan were compared with the approved dose of PPI, which is lansoprazole, for healing and maintenance of healing in patients with erosive esophagitis from US and Europe. And so if you look at here, so they divide it into 2 phases, the healing phase and the maintenance of healing phase. So let's start with the healing phase first. So looking at the primary analysis of healing by week 8, you see that for vonoprazan, it was 92.9 versus lansoprazole of 84.6. So that was non-inferior. And if you go one line down to healing by week 8, especially in patients with severe erosive esophagitis, you see that for vonoprazan, it was 91.7 versus 72.0, which is superior. Now, looking at maintenance of the healing phase, again, for the primary analysis, you see that it was 80.7 for 20 milligrams versus 79.2 for 10 milligrams versus 72.0 for lansoprazole. And again, it was non-inferior. But again, looking at the severe erosive esophagitis patients, you see 77.2 in the 20 milligrams versus 74.7 in the 10 milligrams and 61.5 in the PPI group. So this was actually superior. Okay. So this was the first study to compare a PCAB and a PPI for erosive esophagitis in the Western population. And it confirmed the primary analysis or the hypothesis that vonoprazan was non-inferior to lansoprazole for healing and maintenance of healing for erosive esophagitis. But furthermore, vonoprazan achieved higher rates of healing and maintenance of healing than lansoprazole, with differences seen primarily in those with more severe esophagitis, so your grade C and D patients. And these differences in healing rates can be seen after 2 weeks of therapy and maintained throughout the study. And again, this emphasizes this importance of maximizing acid inhibition and healing and preventing recurrence of more severe erosive esophagitis. So vonoprazan is an effective alternative to lansoprazole for treatment of patients with erosive esophagitis, and especially in those with more severe disease. So now let's talk about its use in H. pylori treatment. So for several decades, treatment landscape for H. pylori has been dominated by PPI-based triple therapy. But we know that eradication rates with PPI-based triple therapy has dropped below 80 in Europe and United States, mainly attributed to the rising clarithromycin resistance. However, it's not just clarithromycin. You also see it rising resistance in levofloxacin and also in metronidazole, compared to much lower rates for amoxicillin, tetracycline, and also rifabutin. H. pylori susceptibility to antibiotics is influenced by intragastric pH, which can modify their stability and activity and also affect the replication status of H. pylori. Vonoprazan increases intragastric pH rapidly and potently and maintains it to a greater degree than PPIs. And this has been associated with a higher H. pylori eradication rate. And actually meta-analysis by Lee with mainly Asian studies, it showed a higher eradication rate than PPI triple therapy. And this was even in patients with clarithromycin resistant strains. So this study by Shea, so this was the first phase 3 clinical trial from US and Europe. And the aim of the study was to compare the efficacy and adverse events of vonoprazan triple and dual therapy with PPI-based triple therapy for the eradication of H. pylori. It was a multi-center randomized clinical trial, so randomized to 1 to 1 to 1. And in this one, this is the primary analysis. So this was no clarithromycin resistance. So everyone was clarithromycin sensitive. So you can see that in the full analysis for vonoprazan dual, it was 78.5 versus triple of 84.7 versus PPI triple of 78.8. And for per protocol, vonoprazan dual went up a little bit to 81.2, the triple went up to 90.4, and the PPI triple went up was 82.1, so it was non-inferior. They also specifically looked at patients with clarithromycin-resistant strains. So this was the secondary analysis. And you can see that for vonoprazan dual therapy, it was 69.6 versus vonoprazan triple of 65.8. And lansoprazole triple was only 31.9. So this was superior. And then all patients is just all comers, regardless of their resistance profile. You see vonoprazan dual of 77.2 versus 80.8 in the triple, and then 68.5 in the lansoprazole triple therapy. So again, this was superior. So this was the first trial providing assessment of vonoprazan-based triple and dual therapy in patients from United States and Europe. And vonoprazan-based triple and dual regimens were non-inferior to PPI-based triple therapy for eradication of H. pylori strains, not resistance to clarithromycin or amoxicillin. But in the secondary analysis, you see that vonoprazan triple and dual regimen achieved higher eradication rates in the subgroup with clarithromycin-resistant strain and also in the overall study population. So in this study, clarithromycin resistance was present at 22.2%. And again, a reminder for the patients who had clarithromycin resistance, eradication with PPI triple was only 31.9 versus for all the patients, it was 68.5. And overall, this again suggests that triple therapy is suboptimal and should no longer be used. Replacing PPI with vonoprazan in triple therapy boosted eradication rates. Okay, so now let's talk about its use in non-erosive GERD. Again, undergoing evaluation, not yet approved. So this was a randomized clinical trial looking at on-demand vonoprazan versus placebo for non-erosive GERD. And basically, they took patients who responded to vonoprazan and were taking it for 4 weeks, and then afterwards did a double-blind placebo-controlled trial. And the primary endpoint was the percentage of heartburn episodes where the patients were completely heartburn-free and had complete heartburn relief within 3 hours. And it has to be sustained for another 24 hours. And so looking at the vonoprazan dose that they use, so for the 10 milligrams, you see that there's complete relief in 56.0% of the episodes. 20 milligram was 60.6, 40 was 70.0, and placebo was 27.3. So overall, vonoprazan was associated with a rate of heartburn relief at least 2 times greater than that of placebo. So I think now the question is the safety profile, since patients will ask you about it as it is a newly approved medication. However, I do want to note that this medication has been around for quite some time in Asian countries already. So vonoprazan has been around for almost 9 years in Japan. So there is quite a bit of its safety profile available for Asians. And I think the question is whether, the data is similar for our patient population. So PPI side effects mainly relates to its effects on chronic acid inhibition and or hypergastromemia. And in general, it is felt that PCABs would not be any different than a PPI. So side effects based on the trials I mentioned earlier include diarrhea, abdominal distension, abdominal pain, nausea, elevated serum gastrin levels, nasopharyngitis, constipation. Serious adverse events were felt to be low, along with events that led to treatment discontinuation. And overall, the side effects are similar to the Asian studies, and PCABs was comparable to PPI. So in terms of dosing, just a reminder here. So for all grades of erosive esophagitis and relief of heartburn associated with erosive esophagitis, initially there's the healing dose of 20 milligrams per day for 8 weeks, followed by a maintenance dose of 10 milligrams daily for up to 6 months. And in terms of H. pylori eradication, the antibiotic dosing doesn't change. What you do is you substitute the PPI with vonoprazan. So you would do vonoprazan 20 BID instead of your PPI. And one thing to remember and to also let your patient know is a good thing is that with vonoprazan, you can take it with or without food. So some take-home points: vonoprazan provided more rapid, potent and prolonged inhibition of intragastric acidity. You can definitely use PCABs in your patients with erosive esophagitis, especially in those with severe erosive esophagitis refractory to PPI. In terms of H. pylori treatment, bismuth quad therapy should be considered the first-line H. pylori therapy, followed by rifabutin or vonoprazan dual or triple therapy. And hopefully, based on the data I showed you, overall, we recommend against PPI-based triple therapy for H. pylori, especially with rising clarithromycin resistance. And last but not least, the safety profile suggests that vonoprazan is well tolerated. Questions, which we'll have later. Thank you.
Okay, now we got the last speaker and we'll go home, right? So my name is Michael Alper. I'm a physician assistant. Actually, it's called now a physician associate. And I worked for the last, 24 years in Fresno, California at California Gastroenterology Associates, and joined that group in January of 2001, I'm sorry. Got out of Stanford, did a short 1 year, 3 months program. Was actually kind of tough. There was a few people that could not complete the program. Usually this talk is done on some kind of medical subject. I couldn't find anybody from academia at that point to do that talk. And then Neil said, why don't you talk? I said, Neil, you kidding me? The guy with the heavy Russian accent speaking in front of you? He said, don't be shy. So I started talking to my friends around the country and asked what's the subject I should cover. And they said, how about if you cover instead of the medical subject, the role of the APPs in GI hepatology practice? So I have a friend on the East Coast, Sarah Anslin. She actually the one who provided me the slide deck, so it's not mine. And it's an interesting subject. So I personally think that, and it will be covered in the slides, that those practices, GI practices, that do not utilize the APPs, they are at disadvantage. Am I stop? Oh, here it is. What am I pushing? The green button? Okay, perfect. Okay, this is my disclosures. Okay, so demand for the APPs. It's the best jobs apparently per US News and the World Report. Number 2 line for the nurse practitioners, number 4 for physician associates. And it's growing and growing and growing. Now, there are some differences in education, for example, right? When I went to Stanford, there was 25 cohort of the NPs and 25 of the PAs. NPs could become a PA as well. PAs cannot be nurse practitioners because they have to be RN prior to getting into the program. At that time, there was no bachelor degree, no nothing. Now it's much more stricter. PAs, we're talking about bachelor degree plus 27 months or 3 years of master's in PA studies. Again, NPs RN with great education, master's in or doctoral, right? Established about the same time, 1965, actually the year I was born, and the PAs in 1967. Number of the in the United States is much more nurse practitioners, 270,000 versus roughly about 140,000 of the PAs. The certification is similar, National Board of Certification for the NPs are renewed every 5 years. PAs, it just recently happened to be 10 years. I always done it every 7 years prior to that. The licensure by state, scope of practice for the NPs, it's independent practice permit in 22 states. In DC, for the PAs, it's in most states determined by the supervising physician scope of practice. In utilization as of 2016, it's about 19% for the nurse practitioner and 14% for the PAs. And this is full practice versus reduced practice versus restricted practice for the nurse practitioners. And this is for the PAs, reduced, moderate, advanced, and optimal. APPs in gastroenterology, I mentioned this already, 2016, 19% of the GI practice employed NPs and 14 PAs practice in inpatient and outpatient settings using a variety of different models. I'm lucky I don't do inpatient. Inpatient is tough in my opinion. Different beast. Integration of APP in GI practice increased in 1990 and 2000, increased demand for the hospital GI coverage, busy outpatient GI practice, screening colonoscopists, subspecialty services such as liver, IBD, and advanced GI endoscopist. according to the ACG magazine, we are indispensable. So increase access to care, that's what it allows to utilize APPs, right? Clinical and endoscopic specialized skill sets, subspecialty clinics, patient education, procedures, advanced research, and quality improvement initiatives. Okay, role of the GI APPs, we're talking about from clinical practice standpoint, we have guideline-based clinical practice paradigms, review, discuss diagnostic tests, results, formulate treatment plans, patient education, risk stratification, referral triage phone calls, and patient messages, and ensure appropriate follow-up, also clinical research. It's very important in procedure patient management, such as indication, contraindication for endoscopic procedures, appropriate timing of the procedures, antithrombotic management, medication adjustment, cardiopulmonary clearance, optimize comorbidities, informed consent, communication, patient, family members, other providers, recognize post-procedure complications. In non-endoscopic procedures such as paracentesis, liver biopsies, gastrostomy, tube management, interpretation of the motility test, hydrogen breath test, fibroscans, high-resolution anoscopy, hemorrhoid banding. Okay, how we can optimize the role of the APP? What's the goals, right? Provide efficient, high-quality patient care, increase access to care, increase patient satisfaction, increase referring, provider satisfaction, improve quality outcomes. Build a collaborative practice, the APP-physician relationship, share patient management. Optimize reimbursement, independent billing by the APP, maximize physician endoscopy time, value-based reimbursement, team-based. Professional development, acquire new skills, increase complexity of patient population, leadership roles, procedures, research, education. Improve retention, job satisfaction, professional growth, opportunities for advancement, sense of belonging to the team. Okay, those are basically important part because actually a good friend of mine from Stanford, Monica Nandwani, she was giving a talk about Stanford had some issues with retaining the APPs. The average is about 8%. The Stanford had issues. They had 16% turnovers. Okay, so they did some study how they can improve that, and that's what they mentioned that you have to create a warm environment around the APPs, greater worth, sense of being valued, professional satisfaction, leadership opportunities, increased confidence, and that will help you to increase retention, right? The benefits of the retention: reduced turnover, experienced providers, increased morale, increased productivity, reduced cost. Gastroenterologists, if you are not using PAs and NPs in your business, you are getting less money and less time for yourself. Did you hear that? Okay. The concept of value, not volume, right? Volume fee for service, no uniform quality, increased demand, fragmented providers. In terms of the value, that outcomes and patient experience, data quality, metrics, team-based, accountable care. Again, this is actually an answer to your question on the test. Billing and reimbursement, right? So you may have independent services, shared, split, and incident 2, site of services, inpatient, outpatient, inpatient excluding critical care, outpatient in emergency department, outpatient established patients only, the billing provider for the independent APP, for the other ones it could be by MD. When the MD, the Medicare reimbursement is at 100%. When it's done by the APP, it's 85%. The role for the APP in modern GI practice evolved and now established partnership collaboration with GIMD, both in private and academic settings, inpatient, outpatient practices, predominantly clinical, but clinical research, education, leadership as well. Pre and peri-post procedural support is very critical. Patient and family communication role is invaluable. Role will mature and further evolve in the future. Increase ancillary testing, AI platform, some endoscopies, digital health. And this is important for both APPs and the doctors that their work-life integration, right? It's not just about, spend time in, doing what you're supposed to do. It's also about taking care of your family, right? We're saying that happy wife, happy life, but it doesn't have to be a happy wife. We need to create something for happy husband, happy spouse, right, as well. We have equal opportunity nowadays, right? So, again, it's very important to keep getting educated. I am always thriving to get more education. And when I learn something, I like to share with somebody else as well. And my motto in life, do not harm the patient. The more you know, the less chances you have to harm the patient. So please use this motto in life and treat your patients the way you want to be treated. Okay, now we have a Q&A session, right, Christina?
Yeah.
And I apologize if somebody did not understand my Russian accent, okay?
I have a question for Neil. This question comes up a lot in patients. I don't think there's any data, but for people that don't have history of C. diff and they're on prolonged antibiotics for whatever reason, not like a 3-day course or a 7-day, but prolonged antibiotics or recurrent antibiotics, what do you tell people that ask about prophylactic probiotics or prebiotics and potentially reducing the risk of incident C. diff?
Yeah, it's a hard answer because there's not a good answer. There's just not a good evidence base for anything you can really do to do that. I'm not generally a fan of pill-based probiotics. I generally advise against any brand of any pill-based probiotic. I don't think bugs come in pills. I think bugs come in food. I think we ingest bugs largely dietarily, and there's a giant smattering of living or fermented foods that I advise to people, and kefir and kombucha and miso and sauerkraut and pickles and all sorts of other good things. There's actually a store in Berkeley all about fermented foods. It's called the Cultured Pickle Shop, and I send my patients there. So I think food is a good, healthy way to augment the kind of diversity of your biome, which is probably the best thing you can do to limit your risk of antibiotic-related consequences, and particularly C. diff. What I talked about with OVP is not for what you're talking about. It's kind of primary prevention, if you will. We use that for so-called secondary prevention, the patient who's had it once, twice, 3 times. Now we're using Vanco as an imperfect solution, but better than nothing, basically.
Dr. Stolman, so I come from a place, I don't want to name it, but you do a lot of necrostectomies. And so I've never, when I was a fellow, we only had one patient that, had a necrostectomy, but only because they were very sick, febrile. But now I just see it a lot just because the patient is deemed a non-surgical candidate. And so, but it looks like from what the ACG recommendations are, it's to hold off as much as possible early surgery. I mean, could you comment about that? Or maybe it's just special place.
Yeah, it's again, it's a pretty specialized thing, right? Not a lot of people are doing either radiographic or endoscopic necrostectomies, but if you have that expertise, it's a consideration. I think the trend, everything is trends. When for us old timers, we understand that. And the trend used to be for earlier intervention, and it was logical to do that. You got an infected bed, it's not perfused, scoop it out. That's literally the logic of that, right? It ain't going to get better with time and non-perfusing antibiotics. Over time, though, there's a significant risk to that intervention too. So we're now suggesting, if you can, wait 4 weeks. That's not a magic number, but that's the number we quote, to let that bed mature, because it's a less morbid intervention if you can. But sometimes you can't. We see these patients. It's a minority. Most of these patients do fine. I got a whole lot of pancreatitis in my city hospital in Oakland, and most do quite well, actually. But that 1 or 2 that are stuck sick as hell in the ICU, if you have to, you have to. But I wouldn't make that a sort of aggressive intervention. I would make that a last resort intervention.
Hello, great talks. I just had a question about PCABs and H. pylori treatment. I know PCABs, you don't need a time for meals, but is there a particular time in terms of the treatment of H. pylori that you would recommend patients to take the PCAB in relation to the medications?
So the medications actually come in blister packs, which makes it really easy for the patients to take it. So for example, for both dual and triple therapy, it'll literally tell you take this in the AM and take this in for lunch and then for PM.
If I can just add on that, I think one of the take homes here is that we've been underdosing PPIs in H. pylori treatment, not in general, probably overusing PPIs in general, but in HP treatment, if you look at the rifabutin-based regimen, it uses omeprazole, generic omeprazole, 120 milligrams a day. That's the omeprazole component of the rifabutin-based regimen. And it works better. It works reasonably well, but normally we're giving people 40 a day, right? So we're, I think, learning that we have been underdoing that. So it makes sense that a PCAB would work, but it would also make sense that even for standard PPI use, we're use more. And again, this little window, I'm not throwing out PPIs to everybody.
Just a quick question for Neil. Rectal indomethacin costs about $1,000, believe it or not, which is somewhat insane. Try to be judicious in using it. In other words, someone that's had a sphincterotomy already and you're going in and just doing clangogram, not using it. But are you saying the recommendation at this point is for everybody to get rectal indomethacin no matter what?
Yeah, I'd heard about that too. It's the same thing that happened with like Vanco for a while. When one person buys the patent, there's one generic maker and they, raise the cost 10x. That'll get better at one point when another generic maker realizes that they could sell it for $500 and still make a gigantic profit margin. So hopefully that will get better. The guidelines overtly, the strong recommendation is, quote, high risk patients. So that is the recommendation in black and white, strong recommendation, good body of evidence, exactly what you're describing, high risk. In the body of the text, when they're talking about expert opinion, and they do say for reasons of cost, so maybe they're wrong with that, but in the body of the text, they say very clearly, yeah, you should probably use it for everyone because that and hydration both work. It's a somewhat preventable problem. So they editorialize all comers, but their official recommendation is high risk. So do with that what you will, Mark. Yeah.
Yeah, I mean, it seems like medical legally, even though it's not in their recommendation, if it's in the text, you're sort of stuck.
Yeah.
I have a question.
Good news is you're not doing it in your ASC, right? So at least you're not that the cost is irrelevant, but it's less relevant in the context of a hospitalized procedure with anesthesia and radiology and other things. On the scale of that, it's smaller.
Can I ask a question to Dr. Cho? The patient come to you in asking you questions about the long-term use of PPI, right? What if they use H2 receptor blockers in the long term or PCAB in the long term? What would be your answer? I mean, in terms of the PCAB versus the PPI in the long term, what's the?
Yeah, so I think, again, kind of looking at how PPI works, the whole idea is inhibition of acid and the hypergastronemia. So overall, it is felt that it would be similar. I do know that there's actually studies that are looking at 5-year data on what the PCAB side effects would be. So once those data come out, I think we'll have more data. But I think overall, though, the idea is that it's probably similar, especially looking at the Asian studies where the PCABs has been available for a longer period of time.
Thank you. Who's doing that?
Marina's going to bring us home, yeah?
Okay.
All right, thank you all. Marina's going to bring us home and we'll get out of here.
All right, we are almost done. So I have a few things to share with you. One is the People's Choice Awards for our posters. As you know, we've had the most submissions of the posters in the history of the GI Symposium, and there are 3 People's Choice Awards. Those folks are getting $200 Visa card, which will be mailed to their home. And the third runner-up is Ernesto Rodriguez. The second runner-up is Danielle Luba. And the overall winner of the People's Choice Award is Elsie Ennen. So congratulations, guys, if you're here. And again, you will be mailed your Visa card to your home address. The second thing is that I would like to announce the Exhibitor Passport Awards. So again, thank you to everyone who visited the exhibitors. And we have 3 people who have visited all the exhibitors and have a full passport. Congratulations to them. They get to pick their gift. So they will get an email from Pace Medical with the choices of their gifts, and they will pick the gift and they will be mailed to their home. So the winners are Dr. Victoria Jung, Dr. Brindusa Truta, and Cindy Guerrero. Again, congratulations. So a couple more things to share with you. If you enjoyed the second part of today's, the hepatology, I invite you all to join us for a hepatology, NCSCG Hepatology Symposium. It will be on January 25th, 2025 in San Jose. So please put it on your calendars. This is going to be a day filled with liver learning. Last but not almost last, I would like to thank our planning committee for putting together this amazing, amazing event. And also, I would like the planning committee to come up here after I'm done talking for a picture. That would be really awesome. I would like to thank our amazing speakers, our sponsors, without whom it would not be possible. I would like to extend special thanks to Pace Medical, who made this absolutely a seamless process. And of course, I would like to thank all of you, the attendees, who really make it so much fun for all of us. And last but not least, I'm going to quote Ted Lasso. Taking on a challenge is a lot like riding a horse. If it's comfortable, you're likely not doing it right. So I want to thank all of you for putting up with me while I'm learning to do this right.